On behalf of the MOC Secretariat, I want to say a warm welcome to the Coordinating Minister for Health and Social Welfare and the Chair of the Ministerial Oversight Committee of the Basic Healthcare Provision Fund, Professor Muhammad Ali Pate, CON, the Minister of State for Health, Federal Ministry of Health, distinguished members of the MOC, international partners, development partners, non-governmental organizations, members and gentlemen of the press, ladies and gentlemen, you're warmly welcome to the 15th Ministerial Oversight Committee meeting of the Basic Healthcare Provision Fund. Distinguished members, it is a profound privilege that we welcome you all to this meeting, and today marks a significant milestone in the collective resolve of the Federal Ministry of Health and its partners, and in the collective journey of achieving universal health coverage for all Nigerians at this very important session. I will invite us to take the the national prayer. Yes, national prayer. Please, can it be projected? May you all rise up to take the second, the national prayer. One, two, go. Amen. At this point, I will humbly request the Honorable Coordinating Minister and the Chair to deliver his welcome remarks. Thank you, sir.
Thank you. The Honorable Minister of State for Health, Dr. Isaac Salako, the representation of the Permanent Secretary, Dr. Dogara, directors of the ministry, heads of agencies, MPHCDA, NCDC, representatives of SPHCDS, our development partners, WHO, UNICEF, UNFPA, and all our development partners are here, members of the civil society organizations, CCM, PVAC, SWAP, and everyone else. I say good morning to you all and welcome to this expanded MOC meeting. I would also want to especially welcome the new secretary of the BHCPF MOC, Dr. Uzoma Okon, who is attending. He's been part of this effort all this while for the last 3 years, but today is his first since assuming the role of the secretary of the BHCPF MOC. The Secretariat, members of the press, ladies and gentlemen. I think we're continuing with this MOC to build on the momentum that we have garnered over the last couple of years. So we've had the practice now of using the MOC to cover the entire sector-wide approach beyond just BHCPF, but also taking talk on the other facets of the Health Sector Renewal Investment Initiative. So I welcome you, and in a business-like manner, I would ask that we just go through the proceedings and take the decision that we need to take and get the updates and the discussions and use the time very efficiently. So on the agenda that you all have, after confirming that in fact we have a quorum of the MOC, expanded MOC, I will ask that we look at the agenda, and I'll pause to ask if there are any observations, corrections on the agenda before we adopt the agenda. I don't see any. Can someone move for the adoption of the agenda? Sorry, Dr. Dogara. No, the agenda. Somebody to move for the adoption of the agenda?
Thank you very much, sir. The chair. I move for the adoption of the agenda as it is. Director Head Planning Research and Statistics, Dr. John Obore. Thank you.
Okay. Well, someone else to second. MPHCDA seconds. So we'll go through this agenda as adopted. The next item is reading and adoption of the minutes of the 14th MOC, last MOC that we had. And the minutes are included in your package, members of the MOC. Please go through it. I did have a chance to quickly look at it with the secretary. So page 1. Page 2. Raise your hands if you have any. Page 2. Page 3. Page 3.
Thank you very much, sir. Page 1, number 7. Sorry. Number 7, Abishola Degoke, Director of Hospital Services, is also repeated in page 3, number 33.
Oh. So, Secretary, you take note of that. In fact, 3 is misspelled. So page 4, page 5, page 6, page 7. Yes.
The abbreviation FMOH and SW, there is need for consistency. Some places is small letter O, other places capital letter O. So we need to have consistency.
Okay. Secretary will note that. So page 8. Yes. Page 8. Page 9. Page 10.
Page 10, line 159, the word which is spelled with capital letter. Chai, which was separately presented by the NEMTC. It's capital letter instead of small letter.
Okay. Good. Secretariat, you will note that. Page 11. Page 12. Page 13. Page 14. Page 15. Page 16. Page 17. Page 18. Page 19. Page 20. Page 21. Page 22. Page 23. Page 24. page 25, page 26, page 27, page 28, page 29, page 30, page 31, page 32, page 33, page 34, 34, 35, wow, page 36, 37, 38, 39, wow. Dr. Dogara, any comment? No comment. There's no comment. So since Dr. Dogara has not commented, I think this is all good to go. Can someone move for the adoption of the minutes? Yes, someone to move for the adoption of the minutes. Dr. Lecky. Yes, you move. Somebody to second. UNICEF seconds. So with those 2 or 3 corrections by Dr. Dogara, the minutes are now adopted as formal record. I think the Secretariat needs to have a very good round of applause for a very, very thorough capturing of the deliberations of the 14th MOC. So let's now look at the action items. Secretariat, can you take us through what we agreed to do? Yeah.
Thank you, Honorable Coordinating Minister for Health and Social Welfare. Can you please put the slide up? Thank you. All right. At the end of the 14th MOC, there were a number of memos that were presented and some decisions that were taken. But I'll just speak to what you have on the screen. It was agreed that MOC members were going to... Okay. On the screen, you have a number of recommendations and some memos, decisions that were taken on memos that were presented at the end of the 14th MOC meeting. I'll just take from the first one. There was a resolution for MOC members to review presentations that were put forth on the platform and to give any, if there are any objections to it, without which the resolutions or the memos would stand approved. And I think that happened. And so the memos number 2, number 3, one coming from the National Emergency Treatment Committee and the memo for disbursement of Q1 were both approved. There also was a conversation around the development of an adherence to some accreditation criteria from the NMTC. That has been done and now developed. I think they will speak to it, Honorable Coordinating Minister, when they give the gateway presentation. There was finally also a conversation around inclusion of Algon representatives, state chairmen across the country to participate in the State Oversight Committee meetings. A subcommittee was set up for the purpose. Dr. Banji, Dr. Ben, representative from DPG, that committee sat. and landed this matter. We have since, as a secretariat, received communication from Algon on all of the state chairpersons and their contact addresses. We've conveyed and communicated that to all the honorable commissioners who are chairs and secretaries to invite them in subsequent state oversight committee meetings. Thank you, sir.
Very important lesson. When you go back to the slide that you had, I think Microsoft Word has a trick. You said 6 resolutions. You listed 5. You said 5 out of 5. But the 6, the private sector inclusion in MOC that you see, you said 6 resolutions as of June 2026. 5 out of 5 resolved, 100%. So you've rigged the actions. Okay. I think we have, this is the second time we deferred the discussion on the private sector, the modalities for inclusion of the private sector. We debated whether the service providers or the general private sector. How do we select one? There was a recommendation. I think Minister of State has provided some input. We could not conclude at the last meeting, and we left the Secretariat to still undertake further consultations on that. But I would want us to actually bring closure to it, since we have committed to include the private sector. So, Honorable Minister, do you have any views, or should we hear from the Secretariat? Maybe we'll hear from the Secretariat. Please, can you address where we are on that, so that we can just close that?
Thank you, Honorable Coordinating Minister. So there was a subcommittee set up for the purpose, and they had extensive deliberations considering a number of the stakeholder groups in the private sector space. And I think among themselves, they had put forward a recommended entity, understanding the nuances of each of the stakeholder groups. And my understanding was that that is the Healthcare Federation of Nigeria. That was what they put forward after their deliberation from the members of that stop committee that was set up. That's the feedback.
So, Minister,
thank you very much, Coordinating Minister, and thank you, Secretariat. My suggestion would be to aggregate all the private sector stakeholders through their identified associations or groups, and maybe allow them to come in turns, maybe on an annual basis. That will allow, because HFN, yes, they speak for the private sector in the health care, but I am not sure that they adequately represent all the key points within the health sector. For example, Guild of Medical Directors, Association of General Practitioners, and so on and so forth, are not part of HFN. So maybe if you aggregate 3 or 4, and then that are very prominent, and then we can get them to take turns on an annual basis to be part of this. So everybody, in my opinion, will therefore have some participation and involvement. Thank you.
So thank you. I think on the basis of the Minister's suggestion, we should bring closure to this, ask the Secretariat to convoke the meeting of the private sector groups, Healthcare Federation, PSHAN, Guild of Medical Directors, Association of General Medical Practitioners, but also pharmacists, nurses, because they are all providers. Easily you would take out professional group, or the private sector groups, but ensure that it's representative. And then let's have a rotational membership. So for them to serve on a yearly basis, but representing the private sector in a rotating manner, so that the constituency is represented, and those that are sitting here with us know that they are representing a constituency. Like the civil society, we have civil society, but I think they function as a constituency. In in a way, they have the mandate of the civil society, and we could see that their interlinkages, they come up, two of them. So we don't want to just take one side, and that once they agree on that as a group, then the next MOC, they should be invited for a year. Then the subsequent sessions, someone else can come in. I think that's a fair resolution that we go about it. We're avoiding a situation whereby we take the healthcare federation that is upstream and then leave those that are on the service delivery side. But if you take the Guild of Medical Practitioners, then what about these are medical doctors? Then what about others that are also service providers in private facilities that are not doctors, even though they are employed in those as private parties? I think that's sort of the we're trying to be inclusive, but also to have the proper representation that has a mandate to represent the private sector. We also mentioned the conflict of interest that may come in the event that actors might come and lobby for PHCPF resources to go to them. This is not the venue. This is a governance mechanism to ensure that the funds are flowing and that there is transparency, accountability. They are aware of what's going on. So we mandate the Secretariat to take that, and by the next MOC, we have a member of the private sector arrived at through that consultative process with the private sector. Fair enough? Okay. All right. Very good. So I think we're making good progress. Now we move to item 5, the gateway presentations. So who starts? NEMTC. Dr. Dobra, over to you.
Good morning, Honorable Coordinating Minister of Health, Honorable Minister of State for Health, Permanent Secretary, ably represented by Dr. Dogara, my directors, heads of agencies. I am Dr. Emoren Dobra. I'll be making this presentation on behalf of my chairman, Professor Ismail Jibrin, who is unavoidably absent. I'll be giving us an update of our achievements and our progress during, on the EMT gateway. I'll be following this outline. I'll provide program implementation updates, both for NEMSAS and RESMAT, our financial reports, financial performance, other activities, both kinetic and non-kinetic, as well as our key priorities for Q3. So for the EMT gateway, we've been able to achieve a national footprint for emergency medical services, either through the federal tertiary facilities or through SEMSAS. Unfortunately, our goal is to ensure that each state has a state emergency medical service structure, and this has not been achieved in Benue and Imo State. Although in these states, we operate through their federal tertiary facilities, for which Benue has 2 federal tertiary facilities benefiting from the EMT gateway, that is Federal Medical Center with Makurdi and Federal University of Science Teaching Hospital Otukpo, while in Imo State, FMC Owerri. Next slide. Now, this is a snapshot of the NEMSAS Connect model. It's our digitalized EMS platform, which we promised to be deployed at the last MOC meeting. We had tried to deploy this, but we adopted a wrong methodology, which is a virtual deployment. We encountered a problem of non-uniformity understanding across all responsible actors that were supposed to help claims verification. So what we plan to do now in this quarter is to bring in all state ICT focal persons from federal tertiary facilities, as well as our primary verification agencies, which is the state health insurance authorities, into one room and ensure we conduct some didactic and simulation exercise to ensure that within 3 weeks, we can deploy this model and ensure that we fast track claims reimbursements, improve transparency in real-time ambulance tracking, performance monitoring, as well as measurement of outcomes. Next slide. For the rural emergency service and maternal transport, we've been able to achieve 81% of the 179 targeted MAMI local governments. Working with the SWAP office, we've been able to properly deploy the Save Mama digital platform. We're currently working with the SWAP office to expand our footprint to the entire 172. We understand that its transition from manual to digital has always been something that's not really accepted, but the SWAP office is really supporting us to ensure we leverage the capacity of the National Health Fellows in these local governments to promote the understanding and properly transition to Save Mama. Next slide. Now, this is the challenge we face, and we think we need to bring it up here. We've been able to provide this transportation across 139 local governments, but only 27 of them have NHIA empaneled CMOC facilities. In that case, we've been trying to advocate to states to scale up and upgrade their facilities to NHIA standards. The NHIA has always been ready to empanel, but the states, on the other hand, and facilities are yet to upgrade. In cases like this, NEMSA still bears the burden of paying for these CMOC cases at both private and public secondary healthcare facilities. Next slide. So this is a slide showing emergency service delivered during Q2. 5,089 patients delivered were supported with service. Highest being labor cases, women transported for during labor. We have 2,954, followed by children under 5, road traffic accidents, obstetric emergencies, neonatal emergencies, other weapons-related injuries. Next slide. Also, NEMSA leverages different modalities of transportation, highest being private community volunteers who support in transporting in the communities. So we have 1,804 private volunteers who have supported, especially in transporting pregnant women in the rural areas, followed by the NURTW drivers who are currently trained on community first aid response to identify danger signs when transporting women and easily contact. So the next slide is financial performance. We'll be looking at the financial performance over this period. Next slide. For the first time, we're able to disburse state operational funds to states. 26 states have benefited from 102 million disbursed to support them with oversight activities, to support their state emergency treatment committee conducting their meetings, monitoring, evaluation, advocacy, as well as to fund the primary verifiers being the state health insurance authorities, who day by day perform these arduous responsibilities of going through manual claims. Next slide. And this is a breakdown of the disbursements or for claims reimbursement. In this period, 324 million was disbursed to both federal tertiary facilities and states. 19 states benefited from these funds. 19 states received 119,153,803 naira 72 kobo, while 12 federal tertiary facilities received 124,889,050 naira 18 kobo. A total of 324 million were disbursed in Q2. Next slide. So this so far from inception, from June, from 2023, over 2.4 billion have been disbursed to both federal tertiary facilities and states, reaching over 130,000 Nigerians with emergency medical services. 1.4 billion has been disbursed to 22 federal tertiary facilities and about 912 to 21 states. Next slide. Within this period, other activities were conducted. The Coordinating Minister of Health and Social Welfare undertook a visit to the Airbus facility in Lyon, France, to initiate high-level conversation around establishing helicopter emergency medical services. This is still at the exploratory phase. We are yet to commence other conversations with our sister agencies, the aviation sector, and other responsible agencies that will be part of this. Also, the president launched 145 rural emergency tricycle ambulances and 79 basic life support CNG and petrol operated ambulances to support our ambulance fleet at both the rural level and the community at the urban level. My chairman also pushed continued advocacy activities, which he normally does. Then there's a collaboration with the NCDC to standardize pre-hospital care as part of the Ebola virus disease preparedness plan. Also, there was a validation workshop conducted for emergency medical service pre-hospital protocol. This is where we also have the standards for approving or accrediting basic life support, trauma centers, our urgent care centers, as well as the human resource that work within the emergency medical service space. We're partnering with MPACDA to provide emergency transport for hard-to-reach women in Kano. In addition, we'll be providing transportation for first antenatal as a pilot using the Save Mama system. We continue to collaborate with the National Health Insurance Authority to link pregnant women from communities to NHI and panel facilities. Our priorities for Q3 is to increase operationalization of this program from 32 to 37 states, then increase our operational status of also RestSmart to the 100% status, working with the swap office, then digitalize NEMSAS and EMT Gateway ultimately in the next 1 month. Thank you very much.
Thank you. NCDC.
Good morning, Coordinating Honorable Minister of Health and Social Welfare. Good morning, the Minister of Health for States, members of the MOC, and everyone here present. My name is Uime Okala, and I'll be making the presentation for the NCDC on behalf of the DG. Our presentation this morning will show the priority disease outbreak that occurred in Q2, our performance at the state, national, and our 717 metrics, what we've done to prepare for Ebola, our Q3 plans, and prayers to the MOC. This slide shows the diseases Nigeria faced between April and June this year. Measles was a high outbreak volume with 2,280 cases suspected and 2,001 confirmed cases and 103 deaths. Cholera was also significant during this period with 8,005 suspected cases, 15 confirmed cases. Borno State had the highest burden as they accounted for over 90% of these figures. Lassa fever continued its endemic run with 1,794 suspected cases and 188 confirmed cases. Diphtheria is still a disease to worry about as the figures are still rising. We had 1,020 confirmed cases and 7 deaths. CSM figures are going down, but the Northwest and Northeast region is still high risk. At the national level, the fund was activated to support national response teams to Sokoto to help support their CSM response. The team was able to carry out investigations to contain the outbreak, to see the size and the magnitude of the outbreak. They were also able to do active case search, case management. They conducted IPC trainings for the health facility health workers and gave them case management commodities. For our state updates, we currently have only 33 states who are operationalizing their basic health care. Lagos, Kano, Borno, and Bauchi states are yet to begin. We are still supporting them to ensure that their bottlenecks are concluded and they can begin. all states have received their first disbursement. Each state received 13.2 million naira, and out of the 37, only 12 states have retired that funds, and 8 states have gotten their next disbursement of 21.1 million naira. For this quarter, we're able to pay 5 states: Adamawa, Akwa Ibom, Bayelsa, Kebbi, and Kogi. Since the inception of the basic healthcare, we've disbursed about 650 million naira to the states. These are the list of the states, 25 states yet to retire their first fund. This is a snapshot of what the fund has done in the states during this quarter. For Imo State, they were able to use the fund to respond to about 200 diphtheria cases. Ebonyi State was able to carry out simulation exercises for their PHEOC staff, media engagement, jingles, and program for high priority diseases, case management across all states, and SAPO management training in Oyo states. For our 7-1 performance metrics for quarter 2, we had a detection rate of 91%, notification rate of 82%, but sadly the response rates came down compared to quarter 1. In quarter 1, we had 36%, but this figure came down to 24% this quarter. Some of the reasons for this is the suboptimal sample transportation within the states. We also have the low diagnostic capacity of laboratories within the states and funding for response. At the last MOC, we were asked to present the trend analysis for the last 3 quarters for the response metrics, and this shows the issues that build up to this are the obtain laboratory confirmation of the outbreak etiology and coordination for the outbreak. Okay, as we are all aware, the WHO has declared the Bundibugyo virus disease as a public emergency of international concern, and the Africa CDC has declared it as a public emergency of continental security. Across the Democratic Republic of Congo and Uganda, as of the 21st of June, there's a total of 1,068 cases with 269 deaths. Yesterday, a case was reported in France. A doctor who returned from DRC, who is currently in isolation, and investigation is on the way to identify individuals who he had contact with. At the NCDC, we've started our preparedness for this. We currently do not have any case of Ebola in Nigeria. We've conducted a dynamic risk assessment, which has rated Nigeria high risk for importation of the disease. We've carried out enhanced surveillance at the different points of entries. A travel protocol has also been done. Passengers of interest have been identified for health monitoring. The national EOC and all state PHEOCs have been moved from watch mode to alert mode. We've developed a contingency plan for preparedness and early response. We've also categorized states to 3 levels: high, medium, and low risk. The high risk states being states that have airports, seaports, or close boundaries to the borders. We also conducted a national and state readiness assessment. The national has been designated at 59%, while the average score for states is 41.5%. We've also identified laboratories who can test for the disease, and currently we have just 9 laboratories who can test for the disease. We preposition critical response commodities and sent them to priority locations. We've also carried out several risk communication and community engagement activities. The DG has been on several national TVs and radio. Then we also had a collaboration with NEMSAS for EVD preparedness. And finally, the Presidential Task Force on EVD Preparedness was established on the 9th of June, 2026, and 10 billion has been earmarked for this purpose. We have not received any fund for this. National priorities. Our priorities going forward is to implement the contingency plan and buy more PPEs and medical countermeasures. strengthen the surveillance at point of entries, train more health workers on IPC, expand the testing capacity in the country, and prepare our RRTs for investigation and response. We graciously received the approval, executive approval from the Honorable Coordinating Minister to disburse 50% of our existing state balance to the states, irrespective of their retirement status for Ebola preparedness. A plan is currently being developed in the NCDC according to each state's readiness gap identified, and the risk assessment done will also determine the amounts that each state will get based on the equity component of our guideline. For our Q3 plans, we intend to continue to support procurement of commodities and send them to high burden states ahead of the next period. We intend to cascade our programmatic and financial report to states, which we feel will help to solve the bottlenecks at the states, and also carry out supportive supervision to the states who are having issues to help them solve their issues. And for the states who have retired, carry out audit spot checks and M&E to the states. Our prayers for the MOC. We respectfully seek the state leadership systems to implement the special state outbreak and investigation and response fund approval we've received in line with the plans that NCDC will send to them shortly. We also seek the support of the chair, Health Commissioners Forum, to please encourage all health commissioners of health to mandate the responsible state officials to retire outstanding and the new funds they will receive within 6 months. And we also urge all states to invest in outbreak preparedness and response actions in their AOP. Thank you.
Thank you very much. Then we'll take MPHCDA.
Good morning, the chairman of the Ministerial Oversight Committee, very distinguished ladies and gentlemen. Please permit me to stand on the already established protocol. I'll be taking the updates on the MPHCDA gateway on behalf of my principal, Dr. Bui Aino. So we begin with the BHCPF 2.0 updates, and then we'll move to the updates on improving access to quality PHC service delivery. Regarding funds disbursement, we can now confirm that we have received the Q1 2026 funds from the MOC, and 9 billion of that fund would be disbursed to existing validated PHCs. We still continue to strengthen financial management processes and improve operational efficiency through the performance and financial management officers spread across the local government areas. Regarding the PHC financial management system, we have 14 states now onboarded, with a proportion of BHCPF facilities across the states having commenced utilization of the platform. We'll have further updates on this as we proceed. The BHCPF training manual has been updated in line with the revised guideline, and we have recently concluded the national level training for the pool of facilitators, and we plan for sub-national trainings to commence from Q3 2026. Regarding the DFF expansion, in collaboration with the states, we have identified 4,700 PHCs out of the 5,212 identified for expansion, and we are still supporting 2 states to identify the outstanding PHCs. Some states have sent in, are operationally ready, but we also have some discuss on DFF expansion, which we will see as we proceed. There's been some progress on the PHC revitalization, with an additional 495 revitalized since the last MOC meeting. We still continue to await the opening of the LGHA TSA accounts. Now, regarding the DFF expansion, one key challenge we have been faced with is in the distribution of funds across states. So currently, the distribution of funds, the MPACDA funds to states is based on the number of wards. So when those funds come in, they are proportionately distributed based on the number of political wards that the state has. So what we have done on this slide is to look at the numbers a state is supposed to get post-expansion, which aligns with the equity agenda. And we have tried to stratify the total numbers expected for each state based on first, which is on the green part of the chart, based on the one per word political commitment. And then the brown part, see the numbers that are adjusted based on equity. So a state like Abia, for example, has 184 INEC political words, and so that has been taken care of. You see that the brown column now is the adjustment made for equity. But when you look at the funds that come to Abia State, the funds available for the DFF based on the current distribution model leaves a gap of 10 facilities every quarter. And so we see the same trend down the states. A couple of states are safe in quotes, and some have surplus. The ones in blue, like Benue, Borno, Delta, will have a surplus every quarter. But we see that for majority of the states, if we continue with the current distribution model, they are going to be in deficit every quarter. So there's a need for us to collectively rethink how we distribute funds across the states to align better with both the one per word commitment and the equity agenda. On the PHC financial management system, like we said earlier, we have 14 states on board, but the average utilization pattern across the states is 75%. We plan to onboard more states in the coming week: Adamawa, Anambra, Delta, Jigawa, Nasarawa, Ogun, and Plateau. And what the PHCFMS does for us is to provide visibility into the facility funding stream. So we have pulled data from the system between January 2025 and June 2026. And what we have done is to look at the total income. Please note that we made some adjustments for data entry errors. So that's one thing we're still going to be working on the FMS, how to have data entry validation rules that limit the errors that will be made during the entry. So we have adjusted that to remove severe outliers from the data. So we can see that across the states, the amount is in millions, so 426 million for Bielsa during the time period. And then we can see the sources of funds stratified by MPHCD Gateway, NHI Gateway, Impact, State Insurance Program. Other sources include partners, community, voluntary donations, and then, of course, balance brought forward as they moved into that reporting period. This also reveals what the expenditures look like across these reporting states. And similar adjustments made for the data, we see that 40% of their funds go to drugs and commodities, 17% go to ad hoc human resources for health, and maintenance gets 13%, which contributes to approximately 70% of the total facility funds. One other key issue we're addressing is the reporting rates across states. So if we see in the previous slide, so states report better. There are more reports coming around the income than around the expenditure. So what we are doing is also collaborating with our executive secretaries to see how we can enforce better compliance. In the coming months, we'll try to phase the use of the PF, try to do a phased progression from paper-based reporting to use of PFMS in identified states to see how we can further strengthen compliance on the use of the PHC financial management system. Regarding the level 2 functional PHCs, in general, there's been an increased progression in the number of level 2 PHCs, but the progress across the zones and states are still varied. However, we had the greatest progress across the northern zones, with the northwest zone showing the most improvement. The the southern zones, particularly the southeast zone, has shown a lot of decline in the last 2 quarters. So maybe probably due to different reasons, but one key reason we have pointed out, which links to the level 2 functionality, is the human resource for health gap, which seems to be widening in these states, as we'll see in the next slide. There are many reasons, there are different reasons that contribute to the level 2 functionality, from availability of reliable power and human resource for health. We also have the staff accommodation and a couple of other factors that link to the level 2 functionality. In this slide, we see that if we look at the HRH, it has shown a 3.8% increase from Q1 generally. But we see that the major decline we find it's around the southeast and south-south zones. So we have been engaging with the states to figure out the best ways to retain, recruit, and redistribute the health workers that they have. Key issues here are significant staff retirements without replacements, and absorption of PHC staff into secondary and tertiary facilities, as were found in Anambra State. Enugu has said that they are going to recruit health workers in the coming months, and we'll be looking forward to getting reports of that and seeing our numbers increase. So regarding the key health indicators we are tracking, the Penta-3 vaccination, women who have attended a minimum of 4 ANC visits, SBA, and general attendance. We had significant progress around the number of ANC4 visits, but it appears that we still need to do more around the number of children who have received Penta-3, the skilled bed attendance, and of course the general attendance, which appears to have stagnated. Keep in mind that these targets have been adjusted to twice that of the set national targets to be able to enable us encourage our states to aspire to more than what the national targets are. So we move on to updates on immunization, HRH, and sexual and reproductive health. The Lagos Vaccine Hub has been outfitted and was officially handed over. It's been officially commissioned. Recall that His Excellency President Bola Ahmed Tinubu commissioned this among the projects that were commissioned on May 29. The rollout of the drive third-party logistics, which essentially enables the delivery of the last mile delivery of vaccines to facilities, is still ongoing. The delivery has now commenced in 9 states as listed on the slides. The last mile vaccine visibility tool has also been rolled out. Health workers have been trained to use this tool. While utilization is still low, we intend to see how we can shore that up in the coming quarters. We've also done some work in expanding the cold chain capacity in 9 states. On the journey to 120,000 trained frontline health workers, we are at 78,000. Most of these health workers we've trained are CHUs, and a significant proportion of these are in the Northwest geopolitical zone. This may or may not be linked to the numbers we are seeing on the HRH slide that I had presented earlier. But this is where we are regarding that training. We expect to see some changes as soon as we are able to train more to reach the mark that we have set. We have also recruited, in collaboration with the states, we have also recruited 3,204 community-based health workers. We have also been working very closely with the ALGON to see how we can redeploy LGA staff who have the qualifications to also function as community-based health workers. And that has begun to show some progress, with 65 LGA staff being identified so far. We plan to recruit over 4,000 community-based health workers across 8 states in the coming months, following the signing of the MOUs in Akwa Ibom, with Akwa Ibom, Benue, Ekiti, Enugu, Kebbi, Kogi, Ondo, and Taraba states. Updates on the RMNC, reproductive, maternal, newborn, and child health. We have some updates on the commodity procurement of commodities and equipment. The Mama Kits, 15 states have now received their supplies. We have also done some work regarding the policy and framework with the collaboration with the Federal Ministry of Health to review the National Sexual and Reproductive Health Policy. We're still working with the Nursing and Midwifery Council to conduct competency-based training in nursing and midwifery training institutions. 380,000 plus women have been counseled and linked to health facilities in 8 states. Regarding stakeholder engagement, we have also engaged traditional and religious leaders during the Religious Leaders Summit that held some time ago. These are the key highlights for the sexual and reproductive health grant as it enters into its 3rd year of implementation, with a total funding bucket of $50 million. It's spread across the 4 key implementers, with MPHCDA going to be focused on improving facility readiness to provide quality family planning and sexual and reproductive health services. We also continue to focus on building the capacity of frontline health workers and related institutions to expand sexual and reproductive health services. The NHIA, the swap office, and PVAC also get a cut out of that budget. Regarding the ECHIS, we have developed the priority core modules to support the MAMI, the SRH, and vaccination tracking. We have concluded the user acceptability testing successfully in Kaduna State, and the impacts of these 2 on maternal and child health service delivery include the 23 million plus children already eliminated, and the community health worker to facility referral loops which have been established. We also have 2.1 pregnant women linked to care. So it has core modules which include narration, child health, vaccination, referral, maternal health, commodity management, and there are other modules there on that too. One key challenge we have faced is the procurement of devices, but that plan to surmount that challenge is ongoing. We're leveraging on the Global Fund grant to get that sorted. What is missing here is the impact on maternal mortality and child health. Apologies, we'll have to include it in the next presentation. But from the data we are getting from the DHIS, there's been some progress on maternal mortality ratios and on the 5 mortality rates, with the on the 5 mortality rates showing a lot of progress. Thank you for your time.
Thank you. Then NHIA. and the MOC Secretariat. NHIA first, yeah.
Honorable Minister, Minister of State for Health, members of the MOC, ladies and gentlemen, please allow me to align with existing protocol. Can I have the slides, please? First, let me apologize on behalf of the DG, who is unavoidably absent. I'll be taking the presentation on his behalf. All right. We'll be using this agenda. First, I'll give an update on the Basic Healthcare Provision Fund and other equity programs, then an update on other NHIA initiatives, and then we'll take a look at the outlook for the Q2 2026. This is a familiar slide, so I won't dwell too much on it, but just to show that a lot of the programs and the things we do align with the first three pillars. And I'll go on to the next slide to show what we have done with that in NHIA. Basically, we're focusing on coverage, equity, quality, and sustainability. So our equity programs are covered under the second pillar. Now, in terms of coverage, so far, when it comes to health insurance, and we're reporting for the whole country, 22.03 million Nigerian residents are covered with some form of health insurance, whether it's private, whether it's social, whether it's under NHIA or state health insurance agencies. And most of the coverage is in Delta, Lagos, Kano, and Kaduna. You can see it disaggregated by zone. In the north, southeast, Anambra is leading, and also in the northeast, Gombe is leading. So this summarizes the coverage of health insurance across the country. So this number represents a growth in coverage across the country since Q4 2023, and so up to date until Q1 2026. So we have an average of a 20% increase, as you can see, steadily growing from then till now. And we tend to increase this, continue to increase this as we work together with all stakeholders. Coming to the BACPF, under the equity programs. Under the BACPF now, we have coverage of 2.45 million enrollees as at the end of Q1 2026. Now, all of them have NIN, as we have gone ahead to ensure that all the data, all enrollment data now must have NIN. And we have successfully disbursed 118.2 billion naira through the gateway since inception. The last disbursement for Q4 2025 totaled 13.8 billion to the states through the state health insurance agencies. You can see the distribution, capitation, which is that the amount that goes to the primary healthcare facilities for primary care is 9.8 billion, and then the fee for service, which is for secondary care, is about 1.6 billion. So this is how much we have covered and how much we have spent under the BACPF, part of the equity programs. Now, still on the BACPF, we have looked at the amount of money that has gone to all the states Q1, Q2, Q3, Q4, 2025, and vis-a-vis the premiums that have been paid, and come up with targets. Given this amount of money, we should have been able to cover X amount of enrollees or beneficiaries. And so this shows the expected versus the actual. And looking at this, we can see that all but 7 states still have opportunities to further increase their enrollment in line with these targets. So far, Kaduna, Kano, Gombe, Edo, Delta, and Akwa Ibom have even exceeded their targets, but we have room for more. So we already notified the states, and as we speak, enrollment is ongoing so that we can bridge the gap and we can do more with the resources we have. And if we get more resources, we can even cover more. So, in addition to the BACPF, we also have other equity programs. For instance, the maternal and newborn programs, the financing access to CMOC. We also have the fistula-free program, which is already been implemented in about 20 facilities across the country, 21 actually. And then I'll speak a little bit about those later. And then we have the Global Fund, financial access for key populations to health insurance. So these are the different equity programs that we have targeting the vulnerable groups. And I'll shed more light on them. So for the CMOC, we've had about 48,591 beneficiaries so far coming to the facilities. Basically, what this covers are the major killers or maternal mortality drivers, hemorrhage, sepsis, preeclampsia, eclampsia, and so on. So we've had quite a number in all the facilities, over 200 of them that's across the country. Then for the fistula-free program, we have about 4,771. And then for the neonatal component, which was the most recent one, we have about 2,904. So based on what we have, people have presented, we have verified claims as well, because it's a case of verifying the claims after the patients have, or the beneficiaries have received treatments, and then we now pay the facilities. And then this is a number of facilities that we have so far for each of these programs. When we come to the Global Fund, we're implementing this in 4 states across Nigeria currently, with plans to scale up. We're in Anambra, Ebonyi, Kwara, and also in Gombe. So far, we have a total of 40,050 enrollees. Most of them are female, 71%. All these enrollment figures, they are 100% NIN verified. And we can see the distribution by disease category or by category. People living with HIV, 33,000. Susceptible TB, drug susceptible TB is 5,697. Drug-resistant TB 564, and then PMTCT 103, making the total of 40,050 enrollees. And we plan to scale this up. So moving on to other NHI initiatives, apart from the equity programs and the BACPF, I think we mentioned this in the last MOC meeting, but we'll still mention this again, that we have developed a tool to digitize accreditation of facilities. And we've already deployed that tool, which we developed in partnership with Safe Care. And accreditation is ongoing for BACPF facilities. And we'll share some of the results with you. Okay, this just shows the distribution of the facilities and where they are, where we have been able to cover so far. Like I said, it's ongoing. And we will be able to do more shortly, but we are constrained a bit by manpower and sometimes security issues. As you can see, the Northeast, there's a little bit, we haven't been able to cover that fully. This is where we are now. We've been able to assess a total of 7,592 facilities so far, out of which 22% of the total, which is 1,656, met all the accreditation requirements. And then 78% of them, 5,936, have one issue or the other that have been flagged for improvement before reassessment. So this process is ongoing, but this is where we are for now. And so we'll continue to update the MOC as we make progress. And we are also updating NPHCDA as we get these results as well. And the good thing about the tool is that it shows the areas for improvement so we can work with the facilities for the remediation. So still in terms of quality, there are some additional reforms that are ongoing. So we are moving from just quality accreditation for facilities. In terms of just saying, okay, you meet the quality criteria, you have the requisite number of staffing, you have the equipment and all that, to empanelment. We want to be able to distinguish that. But the facility has met the quality requirements does not necessarily mean that it's health insurance ready. And so how are we looking at this? We're looking at it in 4 dimensions. First, you have to meet the quality criteria. That evaluates clinical excellence and standard of care. So facility has to be NHI accredited, meets the status, have those standards and safety protocols in place, and we also look at the service delivery outcomes as well. Then again, you have to also look at the financing aspect, the financial management systems, the solvency, the reserves. How do they have audited financial reports and accounts? Do they have those proper internal controls? And then data management is also key. for the NHIA gateway. Is the data of good quality? Is it timely? Is it reliable? So we're looking at how comprehensive it is, how complete it is. Is it NIN validated? Because NIN is a requirement for us. And then also the ability to manage claims and submit data in a timely manner, because that's one major constraint some facilities have. They are not used to managing claims. They don't submit their claims on time for processing. And then the feedback is that they are being owed. So that's one other thing that we've added there. And then for governance as well, we want to review institutional governance mechanisms, accountability, autonomy, oversight, and at various levels, regulatory compliance, licensing, and also very importantly, grievance redress mechanisms are key for our own gateway. So these are the things we are looking at, that beyond just the first dimension, which is quality for accreditation, finance, data, and governance are key, even at the facility level. Yes, so our outlook for Q2 2026, even as we're embarking on all these reforms, one is to finalize the identity validation of current and new enrollees. With this as well, as we are ramping up the coverage under the BACPF by setting those targets, also advising the states that they need to meet these targets for accountability because these funds have been disbursed. We are also tying it to NIN. We are validating the NIN as well. So that's ongoing, and we're going to finalize all that. Then the second thing is to standardize service quality assessment. As my colleague from MPACDA said, we are working on the joint quality of care tool. In fact, we practically finished, so it's just to dot the I's and cross the T's, and that will be ready this quarter. Then we also want to kick off the empanelment of BACPF facilities, round off the accreditation, carry out the remediation, kickstart the empanelment as well. And then lastly, to scale up the global fund enrollment so that we can cover more PLHIV with health insurance, following the success that we are seeing and the good feedback from the pilot. Okay, thank you. I'll stop here for now.
Thank you, MOC Secretariat.
Good morning again, the Honorable Coordinating Minister of Health and Social Welfare, Honorable Minister of State, Permanent Secretary represented, directors in the ministry, heads of agencies, parastatals, other members of the MOC, ladies and gentlemen, thank you very much. I will just take you through the presentation from the MOC Secretariat, and it would essentially follow this outline. I'll speak to BHCPF financial inflows and disbursements, the KPIs, and updates from the Secretariat. So just to say that since inception, the Secretariat's BHCPF program has received a total of 339 billion received, and we have disbursed 290 over the period. In 2025, we received 131.5 billion, and so far in 2026 we've received 48.9 billion. Of that amount, we have since disbursed in 2025 98.6 billion and 32.9 billion for 2026. And I'll just break this down a little bit. We had received in 2025 in tranches of 10.9 billion, again totaling 131.5 billion. And in 2025, we disbursed in 3 batches, Q1 and Q2 came together, and the total sum amounted to 32.8 billion. We maintain that same amount for disbursements of Q3 and Q4. Quarter one for 2026 has also been disbursed, same amount for Q1. In 2026, so far, we have been receiving 50% of what is in the budget, and that has come to 8.9%, 8.9 billion from January to April. In May, we received 13 billion. So just to be consistent with the disbursement of the previous quarters, we had now put for approval a memo asking for the disbursement of Q2 to also, at the minimum, stay on the amount we disbursed in Q1 for MOC to consider. So this is a snapshot of the KPIs. Many of the gateways have already spoken to this, but just to say quickly that we've seen the BHCPF contributing to about 11% of coverage numbers from NHIA. For NEMSAS, we've seen in Q2 that we now have 35 states onboarded, and 32 of them are operational. Still having those gaps that they spoke to. We've also listened to MPHCDA speak on the issues with level 2 standards. We have had from the NCDC a number of responses to events in Q2 2026. There are 35 of them, 35 cases reported. Skill bed attendance in Q1 of 2026, there's reported 414,884, a slight decline from Q4 of 2025. Now, from the Secretariat, just to speak to some governance and oversight issues, recall that we had, at the last MOC, had conversations around activating SOCs and also having Algon participating. We at the Secretariat had, in trying to ensure that SOCs also met as frequently as the MOCs met, would work with our technical teams to develop some templates to enable smooth operations of SOC meetings. We've been able to also ensure that communication goes out in terms of membership of SOCs as per the BHCPF guideline 2.0. We heard about the MPHCDA speaking to the LGA TSA accounts. With the permission of the Honorable Minister and Permanent Secretary, we've requested the Office of the Accountant General to open those accounts, both for the SOCs and for the LGAs. So that is in process. And representation, I've spoken to that. That has been dealt with. Just to also inform MOC that the MOU signed with ICPC, the tax team set up for that purpose, has convened conversations and meetings where the ICPC's plan to begin to track and monitor BHCPF funds have now been activated. They are now about to deploy to the field, and they would like to mirror the deployment to align with disbursements. That's summarily updates from the Secretariat, Honorable Minister.
Thank you. So we'll now open this presentations. These are update presentations. So members of the MOC are invited to comment. I ask that you be brief so that we can go into the second part. Yeah. So raise your flag. Yes, UNICEF. Gates. Okay, so UNICEF, Gates, WHO, PhD shares. Okay, so we'll go in that order first, and then we'll take others. Yeah.
Uh, Good morning, Coordinating Minister, Honorable Coordinating Minister, Honorable Minister of State, and all protocols observed. I thank you for all the presenters for the wonderful presentation. I'll start with the NCDC one. I think it was good to see the data available and the very clear presentation on the funds dispersed. And there is a concern on the low response rate for the outbreaks. It will be good to know what are the reasons for the low response rates, and also for your future to also build it into the key asks for the MOC, the reasons and how to address those reasons for the low response rates, and that is something which is very critical. The funds, one probable reason, just looking at the presentation, could be the funds that have been dispersed may not be adequate enough to match the response needed, and that could be a reason. But there may be other reasons as well, and it will be good to know those reasons. While response is one of the key aspects to control the outbreak, I'm not sure if the funds dispersed would be adequate enough to, given the outbreaks and the magnitude of the outbreaks, the funds dispersed may not be adequate enough to have a more robust preparedness and prevention interventions to prevent outbreaks as well. So it'll be good to also get some clarifications on how that gap is being addressed. The NPHCDA would appreciate the equity-based analysis for the funding, which is very good to see, and also good to see the quarter-to-quarter increase in terms of coverages. Just a question on the ECHIS. It's good to see that it is moving forward. Just to know, but it'll be good to have a bit more details on how the interoperability components and the overall, because we've discussed this in previous MOCs, and how the overall e-health architecture and the interoperability is coming together, which will enable ECHIS to work with other functions, digital solutions that have been developed in multiple other areas, so that the data can transfer seamlessly. NHIA, I think it's also good to see the details of the presentation and the different budgets, allocations. Also curious to know what are the reasons for most of the states to have low enrollment despite funds being dispersed. And just to understand what the challenges are there for the NHIA. The other aspect, it's good to see the funding available for CMONC, and also see the coverage there. Just curious to know if there are any plans, because if you look at the estimated deliveries that would need CMONC for Nigeria, it would be around 1 million or so, depending on what estimates we look at. But the coverage currently is at 50,000, around 48 and odd thousand. So how do we bridge that gap, and what other aspects do we have to bridge that gap? I think I'll stop there. Thank you.
Thank you. I think, let me just say, to recap, to help us make this very efficient, the sectorized approach that we launched in December 2023 was to bring federal government, states, and local government to jointly increase the financing available for health across the three field pillars and to govern it in an open, transparent manner. The BHCPF is an anchor, it's just one sliver of investment. It's not the entirety of the investment of the sector. It's literally half a cent per capita. That's what the World Bank computed, well, less than that actually. Half a dollar, 50 cents. Yeah, it is about 50 cents per capita. So trying to use that and stretch that as a catalyst. The idea being that you fund what we do through MPC Gateway, NHI Gateway, NCDC Gateway, NMD, are not the totality of the funding of the sector. There are also other strands of the general government budget, which you don't see here. There are also other donor-funded programs that you don't see here. We don't see what UNICEF is contributing, what WHO is contributing, what FCDO is contributing, what US government is contributing, what Global Fund is contributing, what households are contributing, what federal government is contributing, even what MPHCD is contributing from general government budget. But at least the MOC is to begin to get us in a way that we have coherence and we are having a focus on the outcomes, and that we take stock through the MOC as we expand the scope of what we take on here, so that instead of having separate meetings, but as a group, once a quarter, we sort of see high level. So when you mention the gap, yes, NCDC is contributing just some few millions of naira per state. The idea is that states should also do that, and the gap that exists in the AOP, if that is done, UNICEF, WHO, CDC, FCDO can place their resources more efficiently to bridge those gaps. Even if it's not in cash, it could be in kind, because there will be in-kind support that doesn't need to come through government. So I just want to put that so that we understand what this is about. It's an expanded MOC to really take stock of the sector-wide program. And the PHCPF is only one anchor, and there are several strands, and there are some more that are not even here. So look at malaria program, look at the HIV program, look at NACA, look at NASCAP, look at other strands of the public finance that is going towards health. We're not addressing that yet, but we should include. So if the states were to give you a sense of their expenditure, you would also get the fuller picture. So don't get the impression that this is it. But your point is taken. So I will ask Gates and then SPHCDA and WHO. And then I'll come to the side.
Thank you very much for the great presentation. Standing on existing protocol. I have 3 questions. My first is on NHIA. I don't know if there's any update on the vulnerability assessment tool, because now that there's the ambition to expand coverage, I think it will be good if we understand how this is going to happen and how people are going to be identified. And then the second is really around the remediation for the over 5,000 primary healthcare facilities that we saw that were on red. Is there a timeline to kind of get them to green and get them to be accredited? Which also links us to just MPHCD facilities receiving DFF. So we know that there's a mismatch between facilities that are receiving DFF and facilities that are receiving capitation. So what is the plan there? Is there a plan to, at some point, either harmonize that list or now engage, I don't know, private facilities? So what's just the update on that? And then my last question is on ICPC. So now that they're now onboarded and there's an MOU that has been signed, can you just shed more light on exactly what their role would be? And just a general comment, if we can also update the times that disbursement from the MOC, because I saw you had that in your slides, but also the gateways, the times that the disbursements actually leave and get to the state, because then when the ICPC goes to do their checks, I think they would need some of those details. Thank you.
Okay. Thank you very much, Honorable Minister and Chair of the MOC. Mine is just to, even though we have many of the discussions in our respective gateways, I'm glad that Honorable Minister explained the point and BMGF just also added a point. I think I want the MOC to know that it's also good that while we are getting some feedback from the output side in terms of quality of care and other numbers that we are looking at, we need to also look at the timeliness of the releases. I remember in the guideline, there's a clear chart that says funds leave like this. For example, I also want the MOC to note that the only disbursement to our gateway is on May 4th, and that is Q4 2025. And when these assessments start coming, is what are we really assessing? Part of the presentation made here was 40% goes into drugs, then 17% goes into HR, and 10%, 17 maintenance, 10% into utilities. And these are key determinants of some of this quality, the acceptance of the services in these facilities. And I saw another practice from the NCDC gateway where they try to address the gaps by trying to see. But we should also be mindful of the fact that this is catalytic. There are needs for us as a national level to see where are the best practices, how can we address the gaps, unlock the challenges in the respective state, and let's also document best practice. For example, the slide presented on L2 declining in some regions. This is where I think, Honorable Minister, we need national leadership to address this issue. Some of the wage disparity across levels in the respective arms of the, even at the state level, is the reason why staff recruited even at the primary healthcare will move to secondary will move to tertiary. It's happening in almost most of our state. So this is where we need high level of advocacy to see how we harmonize these gaps so that we have reasonable retention. How can L2 slip into in that number? I think the quantum is much. Then the last, okay, I think the other point has been mentioned. Thank you very much.
Thank you. I think we'll get the gateways to respond to you. But the point of having the subnational involved in this governance is precisely that. Because then you pick those issues through your platforms, through your commissioners, through your SPHCDS shares to address it at the subnational level, because the issues are not the same in every part of the country. Secondly, while the BHCPF is an anchor, it's not a totality. We're not federalizing the health system. The idea is that states are co-financing, and in many states, the counterpart contribution to the BHCPF is not even coming. I'm not sure, and perhaps MOC Secretary can give us the states that actually have contributed their own, because the BHCPF is expecting 25% and 15% from states and local governments. That has not been happening. So if we're able to capture that, we'll have a fuller picture. The idea is that jointly, federal governments, states and local government will row in the same direction. In many states, there's really not much that is happening other than this token that federal government is providing through the CRF, which is the federal government portion of the overall federation account. So the idea of having these states involved is so that we jointly, through your platforms, advocate for those additional resources to come. And hope, which is also part of this, and we'll hear from SWAP, is to stimulate and reward states when they do that. I was in a room earlier this week, and I know that they're doing a lot, but even then, the equity fund is still work in progress. So WHO,
Thank you very much, and congratulations to all the presenters. I wanted to raise an issue around the skill-based attendance and the decline in the skill-based attendance. Also linking this to the fact that 27% of CMOC facilities were said to be empaneled. So just to find out, also, I think there was also a link to the decline in the numbers of trained, not the decline, but if you compare the numbers of trained health workers in the north to the especially Southeast. Is there something that we need to look at in terms of how we can strengthen CMOC in our facilities? And then also to find out from the partners' perspective, do we need to come together to see, are there some gaps that we can fill? There are some gaps that partners cannot fill. If it comes to infrastructure and all of that, we can't do that. But when it comes to things like equipment and it comes to things like training, if we can quantify the gaps in some of those specific areas, then we can see how we can align to support that. Thank you.
Thank you. Again, sorry, I'm speaking too much as the chair, but I'm trying to provide context. The idea of this conversation is that all of us will succeed or fail together. When these aspects like the retraining is retraining of health workers, we aimed for 120,000, we have had 78,000, and that's where we are. So among our partners, you can pick to do 10,000, 5,000, and then you work with the program to identify those areas and deliver them. So that together we get to the 120,000. So that it's not like a reporting function alone, but a co-creation that we continue, iterate, and solve. It's a problem-solving area, so that we're actually leaning in together, because that is the pact that we had in December 2023, that we're all committing ourselves to achieving these outcomes. So we're highlighting this so that every partner then understands where our pain points, and in your programs where you have flexibility, you can see what fits in most, and then you can step in to do that. Thank you. Shares, we have Dr. Ogara and Dr. Lumide is online, the World Bank.
Thank you very much. My name is Mohammed Safana, the Chairman Forum of CEOs of Shares. First of all, let me use this opportunity to appreciate the NHIA for implementing the CMONC program. Some of the most important takeaways from this is that these patients eventually get enrolled into the scheme through our respective shares. So looking at the information given to us by the NHI on the threshold of the enrollment, I think it's really important for us to reserve some sort of a reserve for such incidences that are coming, so that we have the threshold to enroll them into the scheme. The fact that we have a target to enroll under the Basic Healthcare Provision Fund, the surplus that most of the states have. So I think it's important that we leave some sort of reserve for the CMONC facilities when they are coming, so that we can be able to enroll them into the scheme. Thank you very much.
Thank you.
Thank you, Honorable Coordinating Minister. Thank you for the various presenters. My comments first is on means of verification. I think there is need for us to actually strengthen the means of verification for payment, be it claims from the NEMSAS, whether it's NHIA or DFF. You realize that certain activities are being carried, similar activities are being carried out either by state government or development partners. And once there is verification, they are likely to move those activities by the states or development partners and claim they are the ones that are being done by BACPF, and that gives rooms to duplication of payment and creation of wastages in the system. So we need to critically look at the means of verification and ensure that what we are paying for is actually valid, and there should be value for money. Secondly, the NEMS has made mention that Imo State and Benue State have not been operationalized. I think it is very important for them to bring out the reasons why those two states are not being operationalized, so that the chairman and members of this MOC will look at the issues and ensure that every state in Nigeria is not left out and is being carried along. Then for the NCDC, you made mention that for the disease outbreak. For cholera in particular, 8,005 cases were identified with 73 deaths. That is very high. But my concern is even Borno State has 15%, bears 15% of the burden. Beyond these numbers, there is need for us to critically look at the causes. Why is it that we are having such high numbers in such states? By the time we are able to carry out studies, that will serve as advocacy and will be able to prevent future occurrence. Last but not the least, Coordinating Minister, sir, is on the issue presented by NHIA on fistula repairs. I'm happy that fistula has been captured in the 2022 Act establishing NHIA and is being carried out. But most importantly, as we are all aware, for a woman to get fistula, she's already poor because she couldn't access healthcare services. So these women are already poor, they're ostracized, they are marginalized, many of them are divorced. So beyond the repair, we should be able to have an activity around rehabilitation and reintegration of these women back into the society. This may not be contained in the package of NHIA, but it is important that NHIA also layers with other development organizations and other NGOs that are into rehabilitation and reintegration. So that as soon as a woman is being repaired for fistula, she should have access to something to be done and she should be reintegrated back into the society. Thank you, sir.
DJ and NHI is not here, but I'll tell you that the three components of the FFP is repair, feeding, and integration. I think UNFPA has been very supportive. Ministry of Women's Affairs, ECOWAS, the ministry has been, I think it's a very good point. It's not just repair them, they also get enrolled in health insurance so that they can actually be protected next time that they have. So I think that's a very good one. So you've raised very important points. Dr. Olumide, I'll go to you and then I'll come to my colleague here. Dr. Olumide, are you online? I hear you've raised your hand. Okay. Is there anybody from the World Bank? Oh, okay. Dr. Lumide, Honorable Commissioner Banji, and then Honorable Minister of State. Then we'll move on because we're, yeah. Dr. Lumide. Sorry, we cannot hear you. Dr. Lumide, the World Bank is not in the room. We cannot hear you. Oh, well, he is supposed to be speaking, but he's not. Sorry, World Bank, I think you should have been in the room. Dr. Banji, please go ahead.
Thank you very much, Honorable Minister, and everyone present. Protocols followed accordingly. I'll start with the NCDC presentation, and I note that there are a number of challenges they reported. One around transportation, that has been perennial, we've always known that, but also around laboratory. And I think it gives me a cause of concern. It may not necessarily be in this room, but that's something that we all need to find a way to sit down to address. I say that particularly because I'm aware that the NCDC has regional laboratories across. In my state, for example, the one that is meant for the Southwest, with all the equipment that the NCDC has put there, unfortunately, they've just not had the resources to finalize and complete the building. So we need to think about how to address this. Otherwise, the day we have we've seen it with France, the Ebola or any of these other serious outbreak, then everybody is going to be asking the sector, what have you been doing? So I know the DG has been working out on this, but there has to be a conversation that we need to really rethink how we address this. And I think that's the first thing I wanted to put on board. My second point will go to NPHCDA. And I have, in this instance, I have one question, one comment. The question is around the distribution pattern for the commodities that was shared on the Mami one and some of the other Mama kits, because I saw that there was quite a number of tilts. So is it a case of the states have not responded well, so we know how to ensure that other states who should be involved do this. The second is something I found quite interesting, which was on the PHCFMS data that we looked at. On one hand is, I think it will be useful that the categorization of the revenue sources follow the categorization around our health financing functions. I saw, for instance, MPADA gateway, NHIA gateway, but then I saw impact, right? So which ideally should either be classified in a specific format rather than being called out, except if it was called out for this purpose. But what struck me in that was, even though from the presentation she made, this was early information, is that both Bayelsa and Ekiti had 22% of their revenues coming from their state health insurance, right? If you look at the NHIA presentation, Bayelsa has 325,000 people under NHIA state. Ekiti has 1 million. So the question is, maybe this is a data that we need to further probe, or maybe there's something that the NHIA facilities, particularly those who have 1 million plus or even above 500,000, we need to better understand what is happening with the funding that is going to the facilities. I think that's something that is useful. It's a good way to triangulate what is happening at state level. My final point then goes to NHIA, and it's really around CMOC. I really think that we need to review, right, some of the regulatory requirements for a state or a facility to be considered as a CMOC facility. From what I understand, you have to have a O&G specialist, right, in that facility to be a CMOC facility. I think if all things were equal and standard and we're working in a very controlled environment, absolutely yes. But this is a country that we pretty much, you can ask a 5-year-old, right, to count the total number of O&G specialists we have in the country, right? 1 to probably less than 500 or less than 1,000. And if we do the distribution, is Lagos, Abuja, and maybe Port Harcourt or Rivers, right? So it means that in a number of states, we will not have that O&G specialist, and it means that those states would not benefit. So that's something that we need to think about, either from a policy perspective. I hear it on NHIA that this is their regulation, but I think there's a policy conversation that needs to be had around this to ensure that as many more facilities, as many more states are able to benefit from CMOC. Otherwise, we would have only 4 or 5 states who continue to drive up these numbers, and then the other states are not doing particularly well on that. So I thought those were 3 critical things that I wanted to point out. But again, thanks to all those who have made the presentation. It's much clearer, it's much easier to follow. And congratulations to the new chair of the Secretary of the MOC.
Thank you. I think very good points. At the end, I think we'll come back after the Minister of State. I will have thoughts as well to add to this, but very, very, very helpful. Dr. Olumide, we cannot hear you, so I'll ask Minister of State, and then I'll go to the colleagues to respond. Dr. Olumide, I think we're penalizing you for not being in the room. We can't hear you. We can't hear. We can't hear. We can't hear. Sorry, Dr. Olumide.
Hello, 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 hello.
It's not working. Please go ahead.
Sorry, Dr. Olumide, Coordinating Minister, members of MOC, ladies and gentlemen. My comments first on NMTC. I want to say that personally, I'm happy that the Save Mama number appears to be adding value to what we're doing. But I want to advocate more publicity for that number. For example, the number on some of our ambulances, and also publicize in our publications so that people become more aware of the existence of that number and can therefore, because if they don't know, there's no way they can make use of it. The other thing is that as we'll continue to optimize emergency services, and now that we're bringing the private sector more on board, I think probably we have more ambulances in the private sector than in the public sector. So we have to start thinking of how to also pull private sector ambulances more optimally into what we do. And of course, some of the ambulances that we're donating is also important, if we don't have it, to also develop guidelines for utilization. Because sometimes I've seen ambulances being abused to carry corpse. Some people even take it to markets. So if you do not have guidelines, then it may be difficult to enforce that. So we need to look at a way of doing that. On NCDC, we all know that during COVID, a lot of molecular laboratories were established. I'm sure if you go back and do an assessment of most of them, they are probably, most of them probably not functioning. I've visited some facilities where the molecular laboratories that were created during COVID are just there. They're really not doing anything. So NCDC, I think this is one area we need to think about how to optimize the use of these molecular laboratories in our preparedness. I looked at small comment, but the data that was provided by NCDC, we talked about cholera, and I saw that there were more cholera deaths than the confirmed cases. I don't know, I'm not a statistician, but I think that's something we need to look at. And I also think that NCDC needs to give us some information on the activities by the Ebola Task Force. We're only told that it's been formed, though no fund has been released. But what has the task force been doing? I think we need to also be informed. On NHIA, yes, I think that's been covered. Somebody has spoken about it. So by and large, just to say finally that whereas we still have a lot of space to cover, but I think that what we're doing is clearly showing some progress, and we're also getting some level of global acknowledgement. This week, a rating came out that rated the health services in Nigeria as number 4 in the continent, based on what they call Healthcare Performance Index. So I think that all of us should be happy that at least we're making some progress, even though, thank you, though we still have a lot of space to cover. So what it means for me is that we just need to strengthen and continue in this pathway, and then we can be able to deliver that healthcare service that Nigerians deserve. Thank you.
Okay, thank you. I think the council memo has been passed already on the experienced medical officers to consider them skilled. So the regulatory standard, based on your comment, Dr. Banji, I think the council memo, I think, has been passed. So it's NHIA to reflect that in the regulatory standard, so the skilled medical officers can be considered. But I, just in the interest of time, to say that we'll give the opportunity to the gateways to respond to the comments, but I will make a few comments of mine as well. So why is this important? What are we doing here? This is the governance pillar of the NHSRI that we're operationalizing. Defragmenting, having a single conversation, having a structured way of engaging across partners, government at different levels, civil society, private sector, to take stock of progress as part of the swap, quarterly, joint annually, but the MOC. The BHCPF was conceived as an anchor in 2023. The Attorney General had given a legal opinion that said as far as the Health Act 2014 is concerned, the Ministerial Oversight Committee itself had no legal basis because the Act had put all approvals in the desk of the minister. But having said that, in the context of the swap, we expanded a ministerial oversight so that as a governance, as a policy matter, we bring everybody onto the table and have a conversation about the full breadth of what the sector is doing so that we all row in the same direction. We all mobilize resources efficiently. We track progress together. We hold each other accountable. So it's government, federal, states, local governments, our partners, that we have this conversation periodically. Now, there are some, we've gradually increased. It used to be just MOC, we come and we agree on a disbursement of funds. We've now expanded beyond that, and we'll hear from the SOAP office, we'll hear from others, but there are some key actors that are also, I think we need to bring them into the fold. MOC Secretary, I think you should take that as important as well. So we have the CCM for the Global Fund, which has just completed the submission for the round 8 GC8 proposal, which many of you were involved, but not everybody. So we need to create a space that the MOC, expanded MOC, is also informed as to what that is doing so that we begin to streamline things. Because the Global Fund, Peter Sands agreed in 2023 that GC8 will be folded into the sector-wide approach because the Global Fund signed on that compact. The programs that are key, Take Malaria program, which 15% prevalence is the best it has been of malaria according to Malaria Indicator Survey. Good data. But the MOC is not having visibility, and the malaria program is not getting the opportunity to share what it is doing. Because if you remember those 4 pillars, malaria was part of that in the public health interventions bucket, like IPT, SMC, and things like vaccines. We don't discuss them in a sector-wide manner. TB, there are issues of drug stockouts and all of that. We need to create time so they are not separate islands of themselves. NASCAP, there is a program that the federal government will come up with which would help test and treat, but that is not featuring anywhere for the MOC. I suggest that the expanded MOC makes a bit more time, but we have one conversation, and SOAP will discuss that so that we increasingly, as we're getting comfortable in this governance platform, we also are becoming more and more inclusive, more and more sharing information as to what we are doing rather than just sort of going back again to separate conversations here and there. And finally, the US government MOU. We did agree that the US government MOU, as it becomes operational, that the progress of it, we would invite the USG to be part of the expanded MOC so that there is visibility. Some of the questions that Dr. Banji, you asked about laboratories, the 717, because the entire USG MOU for Nigeria, it was an exception because we built it around the health sector renewal investment initiative. We did not build it on anybody else's plan. We built it on Nigeria's plan because we see it as a path for Nigeria to exit dependency. And so the targets for malaria, for HIV, for TB, the targets for 717, the targets were crafted in the context of the health sector renewal investment. That's explicitly stated so that the MOC gets briefed, and on a quarterly basis we track progress in a transparent manner. That way, this mechanism for the entire sector-wide approach, which is what we've developed, the reforms that we've undertaken over the last 3 years, together with each and every one of you. And the states are here. They also will contribute the co-financing. The federal government contributes, but the states will contribute, will absorb health workers through that. The chair of the Governors Forum was part of the negotiations, part of the agreement, signing of the agreement they didn't sign. But it's important that we problem solve together. This is a problem-solving governance session, not necessarily just a reporting mechanism, because the NHA, in terms of authority for approval and reporting, it says the minister shall, but it doesn't make sense if we are going in a sector-wide manner to bring everyone that then allows the minister to make a decision in the context of the expanded MOC. So the group, I will ask that any immediacy just briefly respond to the comments that have been raised on your presentations, just quickly.
NEMTC, the question was around Imo State and Benue State, why were they not empaneled? We've tried to leverage different platforms and structures to advocate for onboarding these states. We've worked with the Nigerian Governors Forum. Also, we've advocated through the Commissioner of Health Forum, but we've made no achievements. I think at this level, we need another level, high-level advocacy from the coordinating minister and the Foreign Minister of State to assist in reaching out to the governors to prioritize emergency medical service in their states. Thank you very much.
So you'll bring a memo to the state and we'll do that. Yeah.
Yeah, thank you very much. I have many questions to answer. The first one is from UNICEF, right? You asked for, something bordering on the low response rate. And I think the Honorable Minister has given us part of the answer. Majorly, it is funding. And the past, since I got here, the funding to NCDC has always been through mainly the CPF, partner, and appropriation. I must say that in the last 1.5 years, appropriation we've received nothing. So we're totally reliant on our partners, although the withdrawal of USAID fund, US funding has reduced that again, but we still have some partners who are very dedicated to us. UNICEF is there, WHO is there, and that kind of thing. So related to this funding again, the state governments are not funding this again. They're not even participating at all. This is one of the problems again. That's what the Honorable Minister said again. Then people who do not, seek care early for most of these diseases, by the time we did seek care, I say it's gone beyond how it could be saved before developing disease. Still related to funding, this national stockhouse. We used to stockpile drugs, materials, etc. But the last 1.5 years, we'll run out of our stock for obvious reasons. And what we will release for Ebola was something we just kept down just in case. That's why we started releasing to specific areas of need for Ebola now. So immediately funding. And the funding again, sample transportation is also related to funding. A lot of our vendors here that were owing money since last over 1 year. That's the reality of the situation. That's one. Training too, we need to train at the sub-national level. This was required for going to those states again, rapid response teams, to go and do that. There was a question on cholera. That's interesting, and I think I was expecting this. When we disaggregated the data for cholera, we removed Bono. You find that a lot of the cases there, the outcome are not as horrible as it used to be. Death rate has been well less than 1%. For this particular Borno state, we recorded the highest here. And what we found out again is related to what is typical of cholera: water issue, basic sanitation, environment, open defecation. And I think all this is related to, I think something has to do with the dam in Borno state, if I remember rightly again. But we sent people there. When our RIT teams went there, they discovered again a lot of these cases were being treated at the university. They never listened to advice. They were treating them as acute watery diarrhea rather than cholera. And I think that has been stopped now. There are other teams there that have gone there now to address this. Yes, the Honorable Minister of State mentioned molecular labs. There were quite a number of things we inherited from COVID. Molecular labs are one. I think treatment and isolation centers were others, if I can remember rightly. And I'll give you an example of molecular lab in Benue State. When we went there, I think with the WHO rep about 3 months ago during Lassa fever. We were supplying the laboratory within the facility with reagents and consumables. They were wasting a lot of this because their tests were based on NEPA. NCDC does not NCDC does not supply power to the university. And once we started using these reagents again, the power goes. So I think we are starting all over again. So it's wasteful. Those are the things we detected. Why I'm saying this is that some of these facilities were situated in teaching hospital tertiary institutions. These were things were met. And I want to believe that if you have a facility within your environment and you're being budgeted for, I think it does make sense that you should learn to maintain those facilities. What we found out, a lot of these things have been abandoned because they felt NCDC put them there. And I give you an example, the treatment and absorption center in Abuja here, where we went there, we're doing assessment against Ebola. So the terrible state of affairs, we had to shout at the people responsible. So I was going to make 2 requests from the Honorable Minister. One, sir, the Director of Hospital Services, under who those teaching hospitals are, perhaps again they need to take charge or look around again, because we're doing assess all these facilities. Most of them are in horrible, dilapidated state. Most of them. Now, part of the thing we're doing for Ebola now is to assess all the facilities we require, assess the breathing. That's what we found. We've had a list, but some of these have to be put in shape. We're still waiting the funding for that. That's the so for isolation centers, treatment centers, molecular labs. The molecular labs that the Economic Commission for Ekiti mentioned, there were about 7 or facilities mentioned. There were before I came. It took us almost 8 months to request for the release of facilities, and we started now to meet it. We started with Ekiti and Enugu, and then funding stopped. So one funding is released again, we have to start over again because they were going to review the BOP. So these are the realities. The problems we are facing here. Now on Ebola task force, the task force has only met once. First meeting just last Thursday, and it was reconstituted and we met last Thursday and had a plan. But let me say that we did not wait for the task force to constitute, because we started working even when this thing started. And one of the things we do, and I'll give kudos to the Port Health Services again, they were up and doing. Between Port Health Services, us, aviation agencies, including immigrations, customs, and the initial focus was to be on ports of entry. And that's why, again, we narrowed down to those 5 states with international airports. And each state, again, was supposed to work with those airport facilities there. I know when they started, things were a bit bad, but things are getting better, because I know the minister released an entry protocol, which now the aviation agencies are supposed to distribute to all airlines. The plan is that any airline coming to this country, people need to fill that declaration form online so that they can be assessed before coming here, and they need to be screened. But again, they were having issues implementing that, which we're trying to address. Same time, portal services, aviation industry, immigration services are working with various states again to see how they can monitor people coming. One of the slides I would not say a presentation was that at least we've been tracking all people coming from different countries, documented again. People we consider as persons of interest, especially with respect to travel areas to those areas, we are being assessed, monitored. Those are that need to be probably set aside. But again, we note that there are destinations, and this is documented again, and they notify the various states again that X, Y, Z are in your state. Please follow up just in case. This is what it's doing. It's not perfect, but it gets better as we go, as we move along. Apart from that, I know you cannot prevent Ebola 100% from coming in, just in case it comes in, and that's why this preparedness issue had to be involved again. We've looked at laboratory capacities. Apart from 9, we have, like we said, we saw the molecular labs created in some of the states. We're looking at some of the states again to see how we can upgrade those labs again to have the capacity to detect Ebola and that kind of thing. That's one. Like say treatment center, isolation center, they'll be ready. You need to take the staff on case management for Ebola, distribute SOPs to various states, everything like that. They're going around again now. We've done an assessment. We've done a provided plan. We're finalizing a contingency plan with costing and see how best again to address this. I think this is what, like I said, the task force has only met once on Thursday, and I got the minutes of the meeting just about 2 days ago. Task force which I have 4 subcommittees. Each subcommittee is supposed to meet again against the next meeting so that present their plans and their budgets. Thank you.
Thank you, Honorable Minister and MOC. I also have several questions that I will try to go through. Fortunately, many of them have been touched upon by your response, Honorable Minister, and other colleagues. But before I get into it, I'll also like your permission, MOC Chair, sir, to come with a memo specifying what changes we would like in the allocation of the funds to states that lines better with equity, rather than just on a number of words basis, if that is okay. The first question that I got had to do with the interoperability of the ECHIS, and I think that the ECHIS and the EMRs that we're setting up at the primary healthcare system are really part of a broader infrastructure, data infrastructure architecture that is being designed and is being implemented. So you are aware of the NDHI, the Nigeria Digital Health Initiative, which sits under the ministry, and part of the first deliverables of that is to define standards so that anyone in the system that is now really developing a digital infrastructure meets certain standards that fits into the health information exchange. Now, as part of that as well, there's a whole data, I'm looking for the term, Dr. Muntaka, but we have a data, what's the, Well, Dr. Muntaka is coordinating the development of the exchange itself, that all of our interventions will plug into. So you make a good comment, and we are thinking about that. On the BHCPF accreditation, someone asked about the timelines for really remediating all of the gaps that were found. I think the best I can tell you is that we will do it as soon as possible. The first thing we are doing is trying to even understand all the different data sources. The MOC has done certain reviews. We in MPHD have done certain reviews. The NHIA has done certain reviews. So understanding what are these gaps. But what we know is that there's a workforce component, but there's also infrastructure components, which comes with cost. So we will move as quickly as we can move with the resources that we have and with the timelines that we receive the resources with. And like the coordinating minister said, we welcome support, technical and financial, as we move towards the remediation of the gaps. There was a question on the timeliness of funds release. Again, I think what I can tell you, barring a couple of instances here and there across the gateways where there are operational bottlenecks that delay things a little bit, the gateways generally do not delay funds once they get them. So there are release issues at the center. When we get it, the MOC that disburses funds to the gateways disburse to the states. And for the MPHCDA gateway, we tend to do this as quickly as we can. There have been 1 or 2 instances where there were some delays, but there were operational reasons for it that were legitimate, like trying to reconcile certain things, trying to figure out certain pieces of data. But I think that, in fact, that's why when we have accumulations because of a lack of uptake, it tends to happen at the state level. We don't accumulate excess funds or unutilized funds in MPHD. It sits at the sub-national level, and then we tend to have to work with the states to figure it out. But I do think, just to again emphasize what the coordinating minister said, which is that the BHCF is an anchor. It's not all of the funding, but even the current version of it is the federal intervention. And I think the over-dependence of the primary healthcare system on this sole intervention by the federal government, I think, is starting to become unsustainable, and we need to start to have a conversation as the MOC at some point about where do we draw a line, what are the things we're going to do to start to get the states, as they're having more and more resources, to actually step up, and the local governments, of course, to also prioritize primary health care. In fact, it will interest you, Honorable Minister, that in a couple of states that I've personally engaged to try to understand why there's such a rapid decline in human resources at the primary health care level, it's exactly what I believe the chairman of the SPHCDA said, and this is more pronounced in the South, which is that when the states are hiring staff, they prioritize secondary facilities, and in some instances, the state tertiary facilities. So, and what that does is they basically suck the few health workers that they have from the primary health centers, because there's this perception that primary health care is BHPF and the federal government will do it, So I think we need to really do something to change that mindset and start to build some accountability at the sub-national level. One of the things in the short run, the ES of the SPHCDA is, the chairman is here, that we are trying to do to bridge some of this gap, is that where we have unspent resources in the BHCPF MPHCDA gateway, like we got approval from MOC to use it for revitalization in the last cycle. Now we're focusing it on human resources to use it as incentives for the states to recruit health workers to put in their facilities. We're trying to finalize exactly how that will work, but once we lock that in with the states, we will come to you to get official approval for that. There was a comment on the verification of inflows and expenses. I think that is spot on. The goal of the PHC financial management system is precisely moving towards that. But there are, and we thank the states for the cooperation and really uptake of this. But there are a number of steps to it. The first step is to even deploy the tool. You learn lessons in that process, you improve it. We're sort of there now. We're going to scale. So the data that we saw today is incomplete, and to some regards, we're starting to identify the types of errors that are coming in. So we're going to continue to improve it so that it's more complete, it's more accurate, and ultimately, Honorable Minister, even automated through collaboration from the back end with the banks that the health facilities are banking with, so that you can reach that information directly, and then it's less given to human error, it's more timely, and frankly, it is more accurate. Yes. Then there was a question from the Honorable Commissioner on the distribution of commodities. Again, the distribution of mama kits in this instance was influenced by the prioritized mommy locations, mommy LGAs, and the estimated number of pregnant women that are there. Because what we found is that something as simple as mama kits has served as a very strong incentive for women to come to facilities to deliver. So the goal is that every woman that is pregnant should get a mama kit. But again, going back to the point, this is a small intervention that is really driven by the resources that we have, or that we are able to mobilize from our partners. It's not meant to be the full breadth of commodities or that your citizens can access. I think those are all of the important questions. Thank you, Honorable Minister.
Thank you, Honorable Minister. For NHI, I think the first question came from UNICEF. You were asking for the reason why a lot of the states have low enrollment despite the disbursements. There are two ways to look at it. On one hand, there's improved reporting or improved data management from NHIA. So we are seeing this now. I think on the second hand, there's also a very strong peer review mechanism at the level of the forum of the state health insurance agencies. So just bringing out that data and them seeing where they stand with their peers, it's especially under the new leadership that they have, is also stimulating that enrollment. I can assure you, a lot of them are in the field enrolling to change that narrative. And by the time we present next time, you'll see the difference. In terms of CMOC, I think you also asked, how do we bridge the gap? Honorable Minister said a few things around this. CMOC program is just catalytic, right? It's a demand-side financing when these women get to the facilities. But if you want to bridge the gap and cover more women, then we have to think about so many things. They need to be educated, they need to be transported to the hospital, they need antenatal care, and so many other things. We also need coordination and efficient use of resources. And for sustainability, what we do is beyond solving the immediate problem. We also give them access to family planning if they require it, and then we enroll them into health insurance through the state health insurance agencies. So that way they can attend antenatal and also have access to care that will prevent further emergencies. So that's what we're doing on our own gateway, but more synergy across all stakeholders will help to bridge the gap. Another question was, okay, from the Global Fund, I think, or was it the Gates? Any updates on the vulnerability assessment tool? That was Gates Foundation, and how do we roll it out? So, as you well know, the tool has been developed. We've also had some training at the level of NHI itself and also the state health insurance agencies. And so, in implementing the 2.0, there are things we are putting in place. One is the NIN validation, which is already ongoing. All the enrollments now is NIN validated. So that helps you identify who the beneficiary is. The vulnerability assessment is an extra layer. So now this person exists. He has NIN. Is this person actually vulnerable? Should he be part of the beneficiaries, or somebody rich who just found a way to enter into this? And so with the capacity building done, that would also come out with the 2.0 as we are enrolling in the field. We are also verifying, does this person qualify to be a beneficiary of the BHCPF? For remediation, EDMPA-CDA has talked about that, and alignment between NHI and MPA-CDA in terms of the facilities that receive DFF and capitation. We've done some work around that, even though the gateways have their differences, but we've shared data and we're also looking at which facilities receive both. And as we continue to carry out the accreditation and more facilities are coming on board, we continue to update that list. Yes, the comment from state health insurance agencies is well noted. Yes, CMOC beneficiaries, like I said, are enrolled into the BHCPF through the state health insurance agencies. And with this data that is now clear that some states have exceeded their quota, it's obvious from the data that yes, we may need to, or we will need to provide additional financing. I think where the gap is having the data directly from the state health insurance agencies to NHI, which beneficiaries out of all the data on BHCPF came in through the CMOC program. We just have to find a way, add an additional identifier to say, okay, this is the number, and then we include that in the financing and it's sorted out. I think evidence would help us, and we'll work out the details on that. For fistula repairs, the Honorable Minister has said a lot about that. NHIA package and they're going back. Rehabilitation, we talked to other stakeholders in this regard. The other day we were on a call with Fistula Foundation, and they're also doing a lot. So we try to align, make sure that there is no double counting and that they are complementary efforts. And we need to really keep an eye on. And with the financial management system that they are working on, we've also had a conversation on that at the level of the Gateways Forum. And our finance team is also working with them. They will be onboarded as well, and they will be familiar with that. The BHCPF 2.0 is really very clear on what the funds can be used for. Yes, it spells that out. So I think it's basically to work together on that, have one single source of truth with respect to the outflows and ensure that it aligns with what the funds should be used for. And then for the CMOC, yes, we are fully aware, I mean, we are Nigerians, of the human resource gaps. And while trying to hold the line on quality, we take note of the recommendations that yes, skilled medical officers should be considered. We've been discussing that in-house, looking at the task shifting policy and other relevant documents to see how we can accommodate this without also compromising quality. Thank you very much, Mr.
Thank you, Coordinating Minister. So ours was the question around the ICPC work and the disbursements. The co-chair on the health side for the ICPC is here, the Director of Hospital Services, under the leadership of herself, and the alternate on the ICPC side. That conversation had happened, and just to say that the overall aim of that effort is to ensure that there is an ICPC-led tracking of the health sector financing to strengthen transparency, accountability, value for money, and to ensure that there isn't any mismanagement of the resources, and to also say that it's actually a health sector tracking, that joint team. But I think they've elected to begin with what we do within the BHCPF. Yes, what they would not naturally take information from us as per disbursement so that they are properly guided when disbursements have gone out of the gateways to the facilities, so that it's clear what they are tracking. There was a question around the slight reduction in skill bet attendance. Somebody whispered to me that perhaps Nigerians are, maybe not giving us much breath now. But generally, I think colleagues have spoken to the reduction and transitioning of skilled better midwives retiring and being poached out of those funds. But that might be reasons. But that's what the data showed that we presented.
Thank you. So let me summarize at least 4 key solutions or ways forward based on the discussion. First, for where there are gaps, we expect our development partners in the expanded MOC to look at how they will support the states to address we just leave that as something that our partners can look at based on the presentations that we have had. 2, on the molecular labs, NCDC has made a very good argument. It's very urgent that we look at that, and my colleague here is suggesting that we put a small team of the MOC with NCDC, with DPH, with Director of Hospital Services, WHO. I will ask that we add the Africa CDC Regional Director or Regional Head or Regional Advisor with the MOC Secretariat to stock take the state of these molecular diagnostic labs that have been invested upon during COVID across the country, so that when we come back, at least the MOC would have a full insight as to the state and the isolation wards as well. But that the assignment will be done, let's say, within 6 weeks. You submit to the ministers, but you will report back for information of the MOC, because the decision that we may have to make based on, I think, what DG and CDC mentioned. Then on the co-financing of this effort by states, I think 3 years down the pike, we need to restate the responsibility of states and local governments on PHC, and to write to each of the 36 states, and MOC Secretary will need to take lead together with MPHCDA and NHIA in terms of the contributions expected, because we've disbursed in the last 12 years. There have been 15 MOCs that have decided on disbursement of the BHCPF. 5 took place from 2014 to 2023. From 2023 till date, we have had 10 MOCs on time, consistently. 2/3 of the funding of the health BHCPF occurred only in the last 3 years. The first 10 years, less than 30% of the funds were disbursed. So now we need to account for the accrued expected contribution of the equity fund and the counterparty as prescribed by the Health Act, which is a National Health Act, to lay it in front of the state governors and then to ask that they begin to factor that in terms of their contribution, because they're not given to the federal government. They should co-finance the primary health care, which is their responsibility, through those gateways of MPHCDA, NHIA, SPHCDA, SHIA, their LCDC window, as well as the EMTCT window, so that we now begin to, because we have a compact, which they all signed. So MOC Secretariat, that's a key thing that will take forward to begin to address this issue 3 years down the pike. NEMSAS, I think you're going to write a draft that will send to the governor. We'll also bring that to us. So I think that's Algon, you're coming late in terms of when we are out of time. Today is Friday. So I'll give you 1 minute. Make your point succinctly, and then we'll move on to the next part of the agenda so that we can take the memo. Please. You are Algon. You can use your campaign voice. Or you don't campaign anymore.
Thank you. Thank you, Honorable Minister. Thank you, members. I'll be very brief and I'll try to keep to the 1 minute. The first is about the NEMTC presentation, which talked about the National Union of Road Transport Workers for RESMAT. And we had said that most of the local government chairmen have ambulances that can be deployed to do that, because we should be transitioning from the National Union of Road Transport Workers to actual ambulances for transporting pregnant women. The ambulances are packed in the hospitals the road transport workers are bringing them to, and Argon has committed to ensuring that even those ambulances are supported, equipped, and resourced to be able to deliver that service. Coming to NCDC, we've had very fruitful engagement, like you just mentioned about the counterpart funding. We're discussing with all the gateways to see how we can harmonize the counterpart funding from the local government, because a lot of local government chairmen are actually spending money that is not documented, that could actually be put into the system and better resourced as counterpart funding for support. And also we talked about the PAC staffs going to tertiary facilities. And so local government chairmen are saying that they're actually going to pay tertiary facility staff to come and cover their primary care center. So there needs to be that coordination. Yeah, one local government chairman from Cross River State said that's what he uses to cover his primary health care centers over the weekend. He goes to hire because the primary health care workers don't come. So we're discussing with primary health care agency to see how we can harmonize that opportunity. Then coming to the Equity Health Plan Fund of the PACPF for NHIA. The guideline actually specifies that the first step is to get people in the socially accepted register, which is the National Social Register, before NIN, not NIN before NSR, because from the data we have, the Argon currently has a partnership with NASCO. There are 13 million people in the National Social Register that have a verified NIN. So that should be a first pool, and the local government are now decentralizing that figure to local government per local government to create advocacy and actually pay the premium for those people so that we can expand the funding source for BACPF, which has a third part, which is called other sources of fund. Quite a lot of oil and gas companies are, through their corporate social responsibility, are paying for health services to people, which could have been channeled into the BACPF fund under the third tranche of it. So those resources can be galvanized to improve the BACPF contribution to health insurance from 11%. Also, the local government chairmen are also planning to carry out advocacy for the informal sector to expand health insurance informal sector, because the welders, the plumbers, and all that are all operating within the local government structure. So we believe that that support structure, leveraging on the local government system Algon system harmonizing and coordination will improve the general outcome. Thank you, sir.
Thank you for that Algon 1 minute. So that is good. I think NHIA should work with Algon closely and perhaps report back to the MOC on these additional strands that we could use to expand the coverage for vulnerable groups. The Health Act, of course, created a national health system, which Dr. Lekki has been talking about for decades, which comprises the federal ministry, the state ministries, the local governments, wards, private sector, development partners, CSOs, all of us as the national health system, as opposed to a federal health system, state health system. So we're operationalizing it this swap. And what you said, I think NHI in particular, at this point, you should let the DG and you work on that, and we should get as one of the key actions when we meet again in the third quarter. So I'd like to, we're 1 hour past our tea break. Those who want to have biological and tea breaks can still have their breaks, but we'll proceed with the swap presentation in rapid order. I will say 7 minutes each, so because today is Friday. Let's get to the memo and we can finish the expanded MOC. So swap, that's the technical working group and the NCS working group. So please, go ahead.
Good morning, Honorable Coordinating Minister, Honorable Minister of State, PAMSEC representative, heads of agencies, partners, and members of the SWAP National Steering Committee. My name is Heledzira Ganva. I'm presenting the SWAP updates on behalf of the National Coordinator, Dr. Muntaka Umar Sadiq. So today I'll be providing a quick overview on the updates of the SWAP flagship programs and processes, providing key highlights on the progress under the NICE program, and then giving a highlight of the current status of the USG Nigeria MOU, and finishing up with next steps and key acts to advance the UAC and NICE goals.
Please, Adze, may I ask that you have your tea break with a little bit of quiet, please, because the meeting is continuing. Yes, please. Go ahead.
Thank you, Honorable Minister. You would recall, Honorable Minister, that at the last MOC, we had highlighted that there's an interim verification of early and prior results, which was ongoing as of then. And we had flagged the resolution on the grants and loan agreement with the states. Following that, we have continued to gain momentum, and currently about 30 out of 37 states and FCT have submitted their comfort letters for the loan agreements, with the other states currently being engaged. We've also received approval to disburse the funds upon verification of the early and prior results. We've concluded the interim verification and gotten approval from the World Bank, which was also validated by relevant stakeholders, confirming 6 out of 7 of the DLRs. The last DLR is currently undergoing a 2-step verification, and once completed, the report will be submitted as part of the addendum to the already World Bank cleared early and policy verification reports. On MAMI, we continue to drive deployment of the minimum package of systems readiness service across the 172 high burden LGAs. We're working on tracking the implementation of the components of the MAMI MVP, and we have seen improvements from October to now in terms of gaining momentum of the updates of the MVP. We're working continuously to prioritize resource allocation and bridge the gaps. And we're focusing on resource convergence at the health facility and LG level with a focus on integrated service delivery. As we continue to honor the commitment in the compact, Honorable Minister, you recall that in May, we had launched a flag-off event of the CMOC equipment distribution worth roughly about $200,000 per state, which includes essential MNH lab, theater, and pharmacy equipment to be distributed to 251 facilities across 31 states in the phase 1 and 2, with procurement processes for phase 3 currently ongoing. In parallel, we've used data intelligence to inform MVP tracking. We've engaged with NHIA to empanel additional CMOC sites in the MAMI LGAs. And up till date, we have about 259 facilities that have been empaneled by the NHIA, 41 of which are in the MAMI LGAs. On the demand side, we've engaged NHIA through its MNH CMOC program, and they've reimbursed more than 42,000 maternal and neonatal CMOC services between October and March of 2026. As previously presented by Dr. Dobra, we're working with NEMSAS on tracking the ETS in line with the MVP. And we've seen that we've reached about 80% of coverage nationwide in MAMI LGs, offering about 43,000 rural emergency transportation, with a number of them going to emergency transport services, obstetric emergency transportation, and neonatal emergency transport. We're also working with the Save Mama program to transition from paper vouchers to digital models. In February of 2026, the Ministry of Health signed a concession agreement establishing Medipol as Nigeria's national group purchasing organization for pool procurement. Following that, in April of 2026, the SCO and PVAC subsequently signed a framework contract and have disbursed over $4 million to procure innovative MNCH commodities, which has an e-motive bundle to advance the pool procurement and address stockouts in the MAMI LGs, reaching about 1,720 MAMI facilities where complementary services are being deployed. Regarding the NHF, the second cohort was launched by Mr. President in February of this year. And within 3 months, we have started to see tremendous efforts made by the fellows in their various localities in contributing to offering and improving service delivery across their local communities. This we've seen through our show of hands that was done earlier in the month of June. As part of the World Bank IPF, the Technical Assistance Committee, which was launched by the MOC, has convened a number of meetings, and I've worked co-creatively with the states, engaging the honorable commissioners and senior officers in landing on an operational framework of how states will partake in the TA pooled resourcing. This will position them in line with AOP integration and other non-pooled resources that we are mapping through the resource mapping and expenditure tracking exercises to participate in the TA support that will be launching later in the year. And in line with that, the DHPRS, the Department of Health Planning, Research and Statistics, has sent out a circular to commence the 2027 AOPs, which is requesting all federal agencies and partners alike to share, including the programs, to share their priorities for 2027, which will be integrated into the state priorities, and also asking the development partners to liaise with the IPs in the states to work with the states and also share their priorities. Dispatch letters have already gone out, and we're anticipating that responses, especially in terms of this alignment, will be received as of 6th of July, the 6th day of July. So as part of one of our important swap processes, the mini DHS has now been completed, and we believe that this would also be presented later in the day by the DHPRS. The Kano deep dive is currently ongoing. The trainings have been completed, and the enumerators would now be going to the field to commence data collection with an anticipated completion date of August 2026. For family planning, we have supported in instituting a coordination mechanism between federal agencies involved in family planning commodity procurement. This has led to a harmonized planning system. The coordination mechanism has now routinized its engagement, and they've developed a set of recommendations to inform planning priorities for the family planning 2026 procurement process. As a result, we've seen MPHCDA as an integral part of that support within the 2026 procurement cycle. Regarding the USG update, since the signing of the MOU, we've had several joint meetings with the USG leadership, the Government of Nigeria leadership, as led by the ATM task team, and its technical members to jointly co-create an implementation plan that would outline the operationalization of the MOU over the 5-year period. This includes a costed activity plan across all areas of cooperation, as well as an endorsed governance structure, which will be an integral part of, I believe, the MOC in providing updates around the USG Nigeria MOU. As part of that process, we've also completed an IP repositioning process to understand the landscape of the IPs providing service delivery and interventions across the ATM space. We have now landed on about 10, from moving to about 25 to about 10 IPs, integrating their support into consolidated geographical regions, while transitioning other support to government institutions. The IP repositioning and state prioritization exercise currently aligns with the MOU, as well as the GC8, the Global Fund upcoming GC8. We have landed on, we've worked with the Global Fund and the GC8 grant writing team and have completed a nationwide geographic coverage, mapping out partner support for both USG, Government of Nigeria, and the Global Fund across these priority areas of ATM and MNCH, making sure that we're avoiding duplication or overlap of efforts. So currently now, in the next couple of weeks, as part of the IP repositioning and transitioning to government-led systems, the annual program statement for 2026, 2027 has been released and publicized online. And the Government of Nigeria is an integral part of that process in co-creating the next tranche of partners for supporting innovative measures through the MOU. The Government of Nigeria would sit as members of the merit review panel, ensuring that priorities are in line, innovations and priorities are in line with the current status of the MOU and GON. Finally, on the Government of Nigeria co-financing side, and following the directive of the coordinating minister since the completion of the implementation plan. We're now working with various MDAs and stakeholders to develop a procurement plan to meet up with the co-financing arrangements. So before I move on to the key ask, Honorable Minister, I know that as part of the approval from the last MOU, we are also supposed to provide updates of the TWG. So after that, I think a number of TWGs will be providing updates to the MOC on the one conversation, in advancing one conversation and facilitating subsectoral strategic dialogue between MDAs and partners. So as I conclude, for the key asks and next steps, we are asking for an approval of the HOPE PHCP for our advanced disbursements to states that meet up with the SLA arrangements. We're also requesting the GON partners as part of the co-financing agreement to submit their procurement plans that would make up part of the year one MOU commitments. Also following the circular that was issued by the DHPRS, we also request that all partners and health departments, parastatals, to share their priorities for 2027, which will be integrated into the state AOPs. And then finally, we seek for the approval of the inclusion of the ATM program updates as part of the USG MOU, USG GON MOU to the MOC sections. Thank you very much.
Thank you, Dr. Azi. So the HRH, TWG,
Good morning, Coordinator, Minister of Health, Minister of State, Permanent Secretary, Directors, and MOC Secretariat. Permit me to stand on existing protocols. I'll be presenting on behalf of the co-chairs the update from the two TWGs, HRH and NCAS. Next slide. Okay, so for the HRH TWG, it was part of the first phase of the TWGs that was launched March 2024, and we have the following mandate. The co-chairs are the Director, DHPRS, and Dr. Mui Aino from NPHCDA, and then we have the DP co-chair as Dr. Musa Elisha. The three main mandates are around coordination and strengthening of the HRH management at all levels, ensuring that we have a strengthened human resource management and support in the workforce development and well-being across all healthcare facilities. This is the TOR. We are highlighting the two because this has been the focus from the last two TWG meetings that were held. So the fifth SWAP HRH TWG was held on the 4th of March, 2026. And we had the two major mandates that were being pushed around the coordination and strengthening of the HRH management through the optimized use of existing health workforce data for integration and harmonization. Just to give a little bit of an oversight on this, we know we've been trying to push forward on the rollout of the National Health Workforce Registry, IRIS 5.3. It seems like an endless race. Every time we move to the next level, the next version is released. So there was a mandate from the co-chairs to begin to use what we already have on ground existing across the different MDAs, looking at majorly, Federal Minister of Health has done a lot of work around the states that they've already collected the data on. There's some data collected from the swap coordination office, and in terms of CMONC empanelment also from NHI, and then we'll continue to build up and move forth from that. There was also discussions around the change in trajectory, looking at the landscape where we're now looking at elections. So no state really wants to hear about recruitments in terms of spends. So we want to start looking at performance management within the state and pushing forth for the innovations around what many of the states are already doing. So based on these two major outcomes from the meeting, two task teams were formed. One was to push forth on the registry and data establishment, and the second one was to push forth on performance management and recognition. So far, it's still work in progress, but the task teams have begun. And majorly, we have received data from the Swap Coordination Office and NPHCDA. We just received that of Federal Ministry of Health yesterday, so it's yet to be updated onto the platform. And then also, there was a request made from NHIA for the accreditation data to also be released. Based on this, the baseline data received from SWAP was based on the recruitment tool that was developed. This was majorly to push forth on the HopeGov 5.2 DLI, which spoke around ensuring quality of healthcare workforce and availability across the different levels. And the tool was developed to be able to have a baseline of what is available on ground in the states, and we use majorly the swap desk offices to be able to retrieve this. The model also was used to calculate an estimate of what would be required in terms of the recruitment of the new staff, which is what we have as at 4.5 billion for now. And there is a required position to be filled about 55.6%. Noting that this is data only from 26 states. We had 30 submissions, but 4 were a bit questionable. So we continue to push forth. And then for NPHCDA, we have the data of deployed workers at about 76,000 and staff at operational PHC facilities. But what we want to bring to the table is the need for this sort of comparisons, because both the NPHCDA and SWAP data was able to showcase that the most acute areas for attention are around the southeast, which both SWAP and PHC gap was able to show. And also those the one that was improving was also aligned as the northeast zone. We have moderate performance from north central and south south, and then there was also high performance. The best performing was from the southwest. This is in terms of the baseline data from the swap, where we were able to find, but we also found out that a lot of this was majorly as a result of lack of submission. But there's a huge gap in terms of the cadres around EMT, GHU, ambulance drivers, based on what was reported from the baseline data from the swap. So the key findings from the registry and data tax team was on the fact that the Southeast is the most consistently underserved, with the highest swap gap rate nationally at 73% and the fewest staff per capita as such. Then the state that co-investment adds roughly to 12,000 staff is around the north. And then we also have the 55% lower bound to be that of the swap gap calculated through 6 states flagged for data approval. But majorly, we also want to bring to the attention that Lagos and Rivers data was also missing, which stands at about 15 million people to 7.3 million in Rivers. So a lot of this is still work in progress. So with the performance management tax team, the objective was majorly to unify a state-level scorecard for HRH systems to be able to push forth on performance, personnel management, and as well as to find a means of a reward system for recognizing the well-performing states as well as personnel across the different states. So in summary, the scorecard was to focus on the shift from activity-only tracking to comparable states, as well as integration of the 3 lens around the state performance, as well the personnel management, and then the JAR award readiness. And then we would be using an active FTE for productivity measures, as well as the use of verified annual results for recognition and decisions. So the scorecard is designed to be able to showcase 6 major domains as this, and with about 22 indicators cutting across. I'll just move on to the next. So the key implications for this is that the states can now be able to compare using a standardized and weighted HRH performance framework. Personnel management is going to be linked to the state level accountability framework. And then we have a means for cross-border JAR recognitions that would be pushed forth to push on motivation and reward systems. And then the data governance becomes a central means for reporting and timeliness. Sorry. Okay, so in summary, the finalization of the last TWGs that was held was to ensure that we have an optimized system where we are able to use what we already have existing in terms of the workforce, where we have a unified registry that cuts across the different MDAs. So NPHCDA is reporting the same HRH data, Federal Ministry of Health the same, and all the other relevant agencies. And then we would have a finalized HRH scorecard that provides one coherent tool for state performance tracking, personnel performance, as well as JAR recognition decision making. I'll move on quickly to the next TWG. So the NCAS TWG was inaugurated in 2025 December last year following the launch at the JAR. And it was done majorly to be able to fill the slot of the immunization TWG, looking at a broader view of collaboration across both Federal Ministry of Health and NPHCDA. The co-chairs of the TWG are Dr. Charles Nzelu, Director of Public Health of the Federal Ministry of Health, as well as Dr. Mui Aino of NPHCDA, and we have the membership as follows. There was a recognition in terms of the membership to also include civil societies organizations as well as different agencies outlined as such. Were yet to determine those to fill the gap. So the areas in green are what we have begun to track from inception up until this point. And these are the major milestones in terms of achievement, looking from the customization of the NCAS guidelines document to the implementation plan and the development of a finance policy brief. We moved on to the official launch of the campaigns in the pilot states, looking at Kano, Yobe, Oyo, and Akwa Ibom, which has been able to prove that there's possibility for cross-border planning and collaboration for health campaigns. For this year, we developed a cross-departmental planning calendar that sort of guides the activities in terms of health campaigns across the different states. So this was approved at the last TWG. For the NCAS, we had a cross-departmental planning meeting looking at all the relevant IPs across both Federal Ministry of Health and NPHCD and the states as well, building off of best practices and lessons learned from the first pilot of the campaigns. We were able to come down to this calendar for the year, which was initially targeting about 270 independent campaigns, now narrowed down to be happening in just 11 states. That's about 35% decrease of what was planned. And these campaigns are supposed to cut across integration in nutrition, malaria, SMC, MNTE, polio, salmon, and then the PC NTDs looking at lymphatic filariasis, soil-transmitted helminths, trachoma, onco, and schistosomiasis. So far, the TWG has been able to coordinate the activities of the NCAS, and we came up with an annual framework which looks at annual campaign calendar meetings to start off with in terms of micro planning, and then there will be the state socialization meetings with a cross-campaign calendar developed. We would need the TWG's approval before we move on to the next stage, and then the updates in terms of the SOPs that were developed based on each state's independent requirements and needs. Then first operational meeting with the states, which will now translate into what will happen in the states. Noting also that the campaign days depend on what are the different mixes within the campaigns. And then we also always have a post-campaign review that happens. It was very clear from the pilot that in terms of what happens, it is not a fit for all kind of approach. There are different things that happen with different states. So even with the standard framework at the national, there's a need to go down into operationalization of a strategy that works best for each of the states. So this framework is usually given to the states, but they develop it to fit what works best within their own state and and readiness. And then in terms of accountability tools, there's a readiness checklist that is made available. We have an accountability framework that is reviewed by the TWG, and then integration evaluation score afterwards, as well as a compliance and escalation where there are things that need to be flagged. So I'll just move on. In terms of the compliance and enforcement, these are the different levels of raising of the flag in court. So the PMU tracks their issues and follows up with the responsible actors. If it doesn't work, moves on to the tax team, reviews the issues and assigns a corrective measure. This now moves to the TWG if it's not still worked, and then from the TWG it can be escalated down to the minister's attention. And the triggers are what you see on the left-hand side. So we have already begun with the first cycle of the campaigns following the pilots. The first one was in Bauchi. It was very, very successful. We had a combination of sermon that was conducted alongside the polio, and polio was even able to exceed the target, looking at about 112% polio coverage. The sermon was able to meet their target of 85% as such, and then we were able to work using the one team, one visit integrated household strategy. Integrated teams were able to reduce the household fatigue for the recipients of the vaccines as well as the commodities, and there was a flexible team deployment for insecure and hard to reach areas with daily review meetings that were able to track and course correct as we go. The next set of the states for 2026 was Jigawa and Taraba. So these are still in orange because we're still waiting for data to be received, but it was majorly around the SMC Malaria Consortium integrated with the MNCH, and then the SHIS2STH integrated with SMC as well as SMC and STH SHIS2. So before we started, Jigawa was able to showcase that this is something that they'd actually been doing along the side, but the approach that was brought on through the guidance of the TWG was able to show them that what was happening before was just two parallel campaigns happening alongside each other rather than the integrated planning and delivery through a collaborative means. This is what is currently ongoing in June. Bauchi is on track. The campaigns are supposed to start next week. Kogi is also on track with HPV and MNCH about to happen. Niger, there's a problem of time shifting, so we'll be able to align with that, as well as Yobe, that is awaiting inputs for the polio IBRA alongside SMC and NTDs. Kano is being flagged because we have a lot of back and forth with the partners and some areas of lack of compliance. So what the May-June cycle has been teaching us is that a partner accountability framework is very, very key for the success of implementation. Partners can agree to integrate and then they do not deliver. A framework was suggested to capture commitments co-developed with partners, endorsed by the TWG and embedded into the SOP that was developed. In terms of integration, not parallel delivery, there's true integration means that to be able to push on the message that true integration means one team, joint training, and a shared household workflow rather than separate campaigns sharing the same location. Then for nutrition first safeguards, where a feeding prerequisite exists, for example, with the praziquantel treatment that needs feeding before commencement, it is honored even at the cost of a missed window. This was adopted at this session of the integration. Government ownership is very key. States deliver best when they own their own data and then engage government at concept node stage. Partners should involve government when concept nodes are budgets and budgets are designed, and then plow back the pilot lessons. Most new states did not go through the 2025 pilots, and it's like all becoming new for them. Thank you very much.
Thank you for this very good presentation, the ADSI presentation. I would like to just connect a point that you may have missed, which I think is an important one. It's the USG MOU, which has on the strategic investments, the government of Nigeria co-financing. A chunk of it is to help absorb the thousands of health workers who were previously employed through USG programs into government systems. So the gap that the HRH TWG has highlighted, in a way, we now have domestic financing that can be able, we should have that domestic financing working with states as well as MPHCDA to begin to see how we absorb them to fulfill our obligation under the USG MOU once it comes live. So that just to give a sort of a line of sight to a potential pool that will help us address the human resources in a way that is sustainable using government systems. And on the last presentation, I think the point about partners committing and not delivering, I think we all have shortcomings, but I think it's interesting that the working group flagged it. May I suggest that we quickly move on to the mini DHS and CCM presentations and then have brief discussion before we take the memos, as today is Friday. So, Dr. Anthony.
Thank you very much. Coordinating Minister of Health and Social Welfare, Honorable Minister of State for Health, all that protocol duly observed. I'm standing here to make this presentation with a representative of the chairman of the National Population Commission. The ministry had commissioned them to help us evaluate the progress of the implementation of the Nigerian Health Sector Renewal and Investment Initiative through the mini DHS. But before that, we had also commissioned them to help undertake the National or Nigeria Demographic and Health Survey, the main DHS, and a component of that was left, which is the verbal and social autopsy, which looks at mortality and forms the baseline for mortality for before we started the implementation of the Nigerian Health Sector, and Investment Initiative. So with your kind permission, Coordinating Minister and members, I will take us through the report of the mortality study, which is now fully ready. And that a few things to note is that we have added a few things over the years, but for the purpose of the 2024 VASA report, you will find that we added, apart from maternal death, we also added in the report the data for disease or information for diseased women. For the findings, I will just say what you will find when the report is released. You'll find distribution of under 5 deaths, the causes of death, which we have presented, but I'm now presenting on behalf of the MPC. You also look at cause of death for those under 5, even including neonates. And then we also look at antenatal trends. Please let me remind us again, this was before we started the implementation of the N-Street. This is what forms the baseline, and it's part and parcel of the NDHS. So we've noted that those for the deaths that are called for the period under that review, both those who were delivered and those who were delivered at home or in the facility didn't really change. And it's the same thing with the report itself. Because we've made this presentation to the MOC and to save time, I will just go to the big picture, which everybody wants to see. To say statistically, we are still where we used to be before we started the implementation of the N-Street. And by next year, or 2008, we'll be due for the mortality figures, which will show how much progress we have made. And we are confident that by the time we measure in 2028, we would have made a lot of progress. Now to the mini DHS. To mention, a lot of people have asked, why did we not measure mortality in the course of the mini DHS? From expert advice, even if you measure mortality every year or every other year, you would not really find a lot of differences because it's a survey, except you know everybody by name. So what we have done in the course of implementing the mini DHS is to collect data around those inputs and those factors that we feel will influence those mortality and other outcome indicators or coverage indicators. And the key indicator report, it's what is ready. And I am happy to announce that most of the indicators are looking very good since we started the implementation of the Nigerian Health Sector and Renewal Investment Initiative. This is data that was collected recently and is showing that our total fertility rate is beginning to drop. And in the report, you also find what we are seeing across the zones, that there's improvement, even though some zones are making a better improvement. I'll quickly move to trends in teenage pregnancy and birth. You can see that when we also look across the zone, there are differences. They are not different from what we used to see, but like I said, we are beginning to make progress. When it comes to preferences in the use of infertility rate, it's not really changing. We have not seen significant changes, but it's beginning to move. When it comes to family planning, the use of contraception, I'm also happy to announce that we are beginning to see progress in that. Looking at the various methods, we're beginning to see a rise in the use of contraception. And we feel that's a good thing. You can also see the drop for those not currently using any form of contraceptive. We have also, in the report, you also find that we have looked at it across the various zones. And then demand for family planning corresponds with what we are seeing similarly. And then for met needs, even though it's a bit different when you move across the zones, but generally, like I mentioned, we're beginning to see improvement, a drop in unmet needs. Now, in terms of maternal care, trends in ANC, this is interesting because we looked at this data and started interrogating what we are seeing. There's improvement, and then it seemed like it started when we collected the data, we usually cross-reference with what we are seeing in the routine data. And I want to mention here at the MOC that we strongly recommend that the line listing that was being done should continue, because when we looked at the routine data, it showed that there was a lot of gains when we line listed. We are not sure what is happening. When we asked, it seemed like it was flattening out immediately the line listing stopped. But generally, it's looking good that we're seeing more women go to the facilities to deliver. Across the zones, the facility utilization across those indicators are also improving according to the report. And it's the same for all other indicators that we've looked at. The issue of institutional skill that bed attendance was mentioned earlier on, but just to mention that we are now looking at the overall picture. This looks at both the facility and what's happening at home, where we actually in the past have had more deliveries and all of that. So this is the entire picture. When we look at the routine data and look at what's happening at the facility, you see there's marked improvement. But when you put together the entire picture, we're happy that it still shows improvement, but we have said when we measure again next year, we want to see that the improvement has gone more than this. But you can also see in the report that across the zones, there are disparities. The report, when it comes to child health, it's also showing, especially when it comes to immunization, that we are making progress. There is this particular no vaccinations. We say, please note that is beginning to drop almost sharply. So we say whatever we're doing in terms of immunization, please let's keep it up. But we can see that when it comes to rural and urban areas, across all the indicators, we're doing better in the urban areas. So which means that even what we see in the routine data, we need to have more focus in the rural areas. So that's it by zones. Nutrition, stunting, we decided to keep an eye on this indicator, even though it's not an indicator we should measure every other year. But so when it comes to stunting, you will see what looks like we're not making progress. But as you go to wasting, which is something we can measure short term, you will see that we are beginning to make progress. And that's to show that the interventions which we're doing are working, and we should sustain those interventions. So across the zones, we can see that we're making progress when it comes to addressing the issue of child wasting. Underweight, the same thing, progress being made when measured short term. I'll quickly move to another key indicator, which is a quality indicator. In the facilities, we'll be looking at how best to measure this. But overall, when the women were asked, they did say that issues of exclusive breastfeeding as defined, it's improving nationwide. And just to say, for all of these surveys, what we have done is to make sure that we use doctors and nurses at the minimum, so that they know what questions they are asking, they're able to ask them properly. And you'll see in the case of Kano that we tested the enumerators and those who will go to the field to ensure that they're able to speak the language fluently. We're already doing a deep dive in Kano. And the next bit I want to show is that in the report, you also find new interventions like the introduction of multiple micronutrients at the instance of the nutrition program. And then another thing we're exploring with the mini DHS is in this search for, or in establishment of that single source of truth, we're beginning to take indicators from surveys that were being conducted haphazardly and bringing them into the mini DHS, so that we're able to ensure that we promote efficiency in our evaluation studies and reducing the cost of conducting surveys. So you also find HIV/AIDS indicators in the mini DHS report when it's out, and it's showing that we are making progress, especially when it comes to the issues of testing, counseling and testing. So not all the indicators you find here, but we're taking indicators one by one, those that can be accommodated in the mini DHS, and inserting them into the survey. Another I want to quickly mention, it's the out-of-pocket payment. So we said we don't have to wait every 5 years to do that. Let's see what is going on. Who are those visiting facilities? How often do they visit and all that across the regions? It's something we looked at in this mini survey. And we can see the Southeast, the South-South have a lot of visitations. We're going to query in the report why. And then annually, what's admission like? Outpatient, we've looked at the outpatient visits. What's inpatient visits like? What are admissions like across the various regions? And then how much are they spending? Interestingly, if I go back, you would see that the North Central, for example, had a lot of inpatient admissions, right? And then you can see that for the annual outpatient admissions, more happened in the rural areas. But as you go across the geopolitical zones, you can see where they are happening. But who are those spending the money? The Southeast, the South-South, the Southwest. And we have started trying to understand why. We've cross-referenced with things like the number of facilities there, the private facilities, and a whole lot of things, and where people spend big money, and the health conditions and all of that. So a whole lot of why, and trying to understand why this data. But as we move on to next surveys, we'll work with the health financing folks to better understand the spend and where the focus should be. So those are the things you'll find in the report when it's out. It helps us to document what's going on as we implement the Nigerian Health Sector Renewal and Investment Initiative. For this first round, we've chosen Kano to look at for obvious reasons. I will now call on the colleague from the MPC to come tell us briefly what we're doing with the Kano deep dive. And we're hoping as we go into subsequent rounds, we will look at more states to better understand what's happening at the local government and what level. But I'll just call on him to make the presentation. Thank you very much.
The Coordinating Minister for Health and Social Welfare, the Honorable Minister for State of Health, all protocols duly observed. My name is Philip Osung, and I'll be providing a brief update on the implementation of the Kano Mini DHS on behalf of the NPC. So as a background, the survey is currently ongoing across the 44 local government areas in Kano State. Across 615 enumeration areas, we have 37 interviewing teams, and the field work is going to last for 70 days. We are currently on the 27th of the field work. The funding for the survey is from the Gates Foundation through ICF, with disbursement being done by Deloitte, and also Gavi funds being managed by the WHO for the survey. So the Gates funds is covering the survey operations, procurement, and training, and the Gavi funds, the payment of the data collectors. In terms of the activity timeline, we are currently in the data collection phase, and this is going to last through August 8. As noted in the SWAP presentation earlier, so far we are about 35% completion in terms of the fieldwork progress rate. We've covered about 6,000 households, and about 3,000 children have been tested, been measured so far in terms of collecting anthropometric biomarkers. Quickly, we've had, in terms of challenges so far, we've had two major challenges. One is in terms of logistics. So in terms of how the funding was structured, the Gavi funds via the WHO was to take care of securing the fieldwork vehicles. However, the procurement process could not be completed by WHO before the May 30 deployment date. And because of that, the field workers were deployed without vehicles for about 24 days. However, to sort of manage this, the WHO team had the team had come together and agreed that the data collectors will be paid transportation stipends for 24 days of field work. But then we found that this was very, very tasking. Some of the biomarkers had to carry some of the shortboards, the instruments that they're using in the field, and we felt this was going to impact the quality of data. And the team came together to sort of look at the stopgap measure, and this was to allocate funds from different budget line items to cover for the logistics, with WHO commitment that when we get to those line items, the funds were reallocated from, that they were going to cover those. This is not ideal, but we did hope that perhaps in future surveys, this process could be completed on time to be able to address this issue. So in terms of the current status, the vendors have finally been identified and the deployment are currently ongoing. Now, the second and the most critical challenge that we have in the implementation of the survey so far is on the payment of the field workers. The team had agreed to pay the field workers in 3 tranches. The first tranche after 30 days, which is due on Monday, the 29th, and then the second tranche, and then the third tranche at the completion of the field work. In terms of the challenge now is that about 3 days ago, the WHO has reached out, the team in the country have reached out to note that hotel receipts and transportation receipts will be required from the about 400 field workers that are currently in the local governments working in the communities. And this has never been the practice, not in the national mini DHS that was just completed, and not in the previous survey, because the agreement with the field workers was that they will be paid an allowance, of course, which they are going to deploy as they see fit to carry out the task. So introducing these requirements mid-field work threatens the payment and the morale, and they are waiting for money on Monday. If this is not addressed, we feel like this may likely impact and derail the field work as it is. So we hope that there will be an engagement with the WHO team to assure that payment is made to the field workers on the 29th without delay, so as not to threaten the morale and also negatively impact the field work that we've all invested so much in. So in terms of the request to the steering committee from the mini DHS team is one to approve the draft VASA report for dissemination, approve the draft key indicators reports of the mini DHS for use for programming and decision making, as has been presented by the Ministry of Health, and then note the challenges faced in the implementation of the Kano deep dive, and also help with facilitating discussions towards addressing them so that the integrity of the field work can be protected. Thank you very much.
Thank you. I think CCM, you have 7 minutes, Dr. Tajuddin, so that we can make progress, please.
Good afternoon, sir. Permit me to ride on the already established protocol. I will try to make the presentation within the 7 minutes, but I'll be speaking on HIV, TB, malaria, and health system. So, sir, you may probably consider. Thank you, sir. Okay, thank you very much. The outline, I will provide brief update on disease burden for HIV, TB, malaria. Then I will speak around the GC8, the processes, as well as the principle around the prioritizations that we embarked on during the funding request. Then possible expected outcome after the implementation of the grants. Then integration, risk associated with some of the decisions that we've taken, as well as next step. What's going on? The roadmap we've done with submission, which was June. So we are currently waiting for TRP feedback. The documents were completely submitted. Then there were 1 or 2 clarifications which we responded to. So the TRP have acknowledged receipt of our documents for review. We received allocation letter, which was 791.6 million US dollars. This was a reduction from the GC7 that we are currently implementing. 50% reduction. GC7 allocation was 933.1 million US dollars. However, within the context of the allocation letter, we were reminded of the need to reduce the number as well as the structure of the implementers that we are currently using, and then to facilitate across programs as well as functional area integration. Then leverage strongly on already existing programs or structure at both states and local government to eliminate any form of duplication. These are the principles that we've factored into the grants application. The first is around the cross-program coordination and alignment, fully alignment with the sector-wide approach. The second is to talk about evidence translations so that whatever we are doing, we'll base it on data that we can back anytime, any day. Value for money, no wastage across the HIV, TB, malaria, and all activities that we've advanced for GC8 are those activities that if Global Fund resources is not forthcoming, are something that government of Nigeria with other partners will be able to sustain moving forward. This is primarily what we respected so much, and then we that guided the funding request. Prioritization of intervention across universal health coverage with the national health sector blueprint and sector-wide approach as the principle for the activities. Then expanding health insurance, that's the pillar 2. The next is strengthening supply system, which talks about how we're going to source the products or consumables that we are going to use, looking at local manufacturing first before any other product. And the next is around the integration of climate into whatever we are doing as health intervention. Then primarily we focus on strategic shift, which talks about country ownership, integration, sustainability, as well as transition, because the country decided under the leadership of the coordinating minister as well as the CCM chair that we are using GC8 to transit all whatever Global Fund resources has been using to implement in Nigeria since inception. Then we focus our integration on the 6 sub-headings: human resource for health, commodity supply chain management. So moving forward, you agree with me that HIV, TB currently are not using the same platform to distribute the commodity. For GC8, we want to ensure that the last mile delivery is done with one vehicle for HIV, TB, and malaria products as much as possible. Laboratory services, we also want to strengthen the lab services to be able to screen HIV, TB, and other opportunistic infections. Surveillance and data system, we want to use one SOMA system for every other surveillance, as well as using one system to capture data. Community system. This time around, the community system will be based on broader engagement. We have currently HIV CSO, malaria CSO, TB CSO, and they are in all the 36+1 states. So moving forward, if you are CSO, you have to learn how to implement HIV or support HIV, TB, malaria, as well as other public health disease conditions. Then health financing. So the implementation arrangements, from 7 principal recipients, we reduced to 5 principal recipients. And this time around, we have just only 1 principal recipient coming from non-governmental sector. And that was probably to address any risk that could happen in the course of grant implementation. And that's enable us also to implement what we call dual track financing mechanism. And that we facilitate high risk averse, then it will also support grant readiness, then government more involvement to address fragmentation and other integration that we've put across. There was no allocation for for health system, but the country decided that we cannot deliver HIV, TB, malaria without strong health system. So with consultation with country team, global fund and stakeholders in country, 6% of HIV allocation, that's from 18.4 million. Then 2.5% of TB allocation, 3.3 million, as well as 6% of malaria allocation, 21 million, was allocated to RSSH, and that gives RSSH an envelope of 42.8 million US dollars for 3 years. This is HIV. For HIV allocation, we have 289 million that is left. But because of other activities that are not able to reflect within the funding envelope, so we have what we call priority above allocation, which means if there is efficiency globally, and then we are able to absorb our funding as quick as possible, we will be talking to Global Fund to help us look for additional money of 303 million US dollars for HIV. Then for TB, we also put priority above allocation of 100 million plus the allocation of 129.6 million US dollars respectively. The priority was based on some of these activities: situation analysis, CCM-led ranking, country dialogue, and we've used also epidemical data to arrive at what we agreed onto. But I will use this slide to just briefly explain what we consider as current situations analysis. For HIV/AIDS, before now, we used to believe that our first 95, we are already at 95%. Unfortunately, during the funding request, we were able to engage, and then this exercise that happened in Akwa Ibom in 2024, which early 2025, which the result was released early this year, shows that in Akwa Ibom, where such activities has been implemented for years, the first 95, that is the PLHIV that knows their status, was below 50%. So that necessitated decommitting and then rebasing our target. So for HIV that knows their status, it's now stand at 80%. What this means is that it has implication also on the MOU with USG, because currently what we have in that MOU shows about 94, 93% as baseline. So we may need to reconsider this. Then for the number of PLHIV that knows their status that are on treatment, based on the Akwa Ibom AIDS impact survey, we discovered that it's now 78%, no longer 98% as it was captured in the MOU for G2G MOU. Then the viral load suppression was about 96%. Now it stands at 94%. The activities that we put across for GC8, we prioritize prevention. Then we also try as much as possible to factor the triple elimination of vertical transmission. So that is PMTCT, which will be implemented in 36 plus 1 states. However, for the funding envelope, only 14 states were captured within the funding envelopes. So if we have efficiency and then there is resources from other sources through Global Fund, that means we are going to other states. But if not, we will be in only 14 states, and then the resources available for that is 34.8 million. Differentiated HIV testing, this time around, efficiency will be factored into what we are doing. We are not just going to everywhere to test, but we will be using index case and then other data to prioritize testing. Then treatment, care, and support with 105.6 million US dollars to procure the commodities. Then the expected result by 2029, we hope from what intervention we've put into the funding request, we are going to move PMTCT coverage from 61% to 95%. Then we are going to move HIV testing from 34 to 90%. And then we are going to move HIV testing for pediatrics from current 58% to 90%. And adult first line will be moved from the current 80 to 95%. For tuberculosis, we have small challenges around the tuberculosis. Over the last 3-4 years, we've been surpassing our target. And for the purpose of resource allocation, the 2025, which we are using as base for TB, the target we have in the grant was 370,000 cases to be detected. Fortunately or unfortunately, we have 455,112 cases that, as of 2025 December, that we were able to screen and place on treatment. So that puts more pressure on the TB allocation. Then we also prioritize based on some of the data that are available. Currently, only 40% of facility offer TB services. And then 9 states of 36 plus 1 state are responsible for more than 50% of TB notification. Screening within childhood TB also has been a challenge. And in that case, we have for DRTB cases is on the increase because the more we are not able to identify the TB, susceptible TB patient on time or place them on treatment with low treatment success rate, then we are recording more DRTB cases. So for the TB modules, we have about 8 modules with the diagnostics, treatment. Then we also look at TB HIV because of the relationship co-infection rate. Then we are also talking about program management with also monitoring and evaluation. For expected results, after 3 years of implementation, we hope that from the base of 2025, we are going to move to 524,302. More importantly, we believe that with the TB treatment coverage as at moment, it was a stand at 88%, we will move to 90%. Then the TB patients with documented HIV screening, it will move from the current 94% to 98%. And with that, eligible contact tracing will be done for all TB patients by, with hope to reach 704,000 TB patients across the cascade. TB HIV collaboration, we are currently at 12% time of co-infection. It was 12% co-infection in 2018, but now it has reduced to 4%. So which means what we've been doing is actually working, and then we want to continue in that manner. TB patients with documented HIV status, we've been able to screen 98%. So co-infection patient on ART, 93% screened. Then 76 versus 87% when it comes to TB HIV collaboration. For RSSH component of TB HIV, the investment that goes into that intervention, considering the fact that we need more of health system. So within HIV TB, we were able to invest more around health system. So this is what it goes in terms of MIE, laboratory. Then for malaria, co-financing. This for HIV TB, currently we are doing 1.2 trillion as a government across the 36 plus 1. For GC8, we put 1.18. The reason being that the exchange rates we used when we were preparing GC7 was different from the current exchange rate. So that affected the volume. The malaria RSSH, for malaria we have 329.6 million. That's within allocation. Then 42.8 within allocation for RSSH. We prioritize also using the same burden, the same prevalence information to decide on priorities as well as the modules that we put across for malaria. The primary problem for malaria is for the national strategic plan developed for malaria, the available resources to implement malaria activities is far, far, far less compared to what malaria required. So we are having gap of 736.8 million for only 2027 if we are to implement malaria hand to hand. Then the interventions, we look at preventions, we also look at diagnostics, then surveillance. For expected results for malaria, if all things goes well, we hope the prevalence of 15.2% will also be maintained, looking at the funding challenge. Then the population that sleeps under ITN will also increase from the current 40 plus to 64%, and then effective diagnostic will also increase to over 90%. So the resources allocation for the malaria modules, vector control, then we have almost 57.5. Then for continuous ITN distribution, 4.3. Then annual national continuous distribution, ANC and EPI, 12.5. Then quality and intelligence surveillance, we also have resources allocated to that. For RSSH, we have about 12 modules for RSSH. But these 3 modules are prioritized because they are the quick win that will give us better result when it comes to integration. Earth products management, 1 warehouse, 1 3PL, then 1 distribution. Laboratory, 1 earth workers, as well as community. HIV, CSO, TB CSO, they are no longer going to be operating in Fatica. Then the other modules are earth financing, then earth sector governance. That is where we have resources allocated to sub-national level, like states, commissioners, DPH, to galvanize their opinion and support. Then the ALGON also will be doing some level of coordination with national MDAs. Integration, PHC has been prioritized. Then credible co-financing, looking at all what has been presented so far today. This is the pillar of integration. We look at leadership, earth financing across all the 12 modules. Then the risk that we need to be mindful of, if all what we've put across will be successful. Procurement supply chain, we need to look critically at the source of the commodity required, how we are going to do the procurement, and then some policy change that is required. Currently, HIV and malaria goes to facility bi-monthly, TB goes quarterly. There is need to have a decision on how to match the distribution to either quarterly or bi-monthly. Data flow and data use. This is inevitable. We want to move away completely from paper-based where possible. And we want to use one platform for data reporting. Then financial and fiduciary management. In the GC8 grant, we also factor some level of investment around public financial management system. That will provide opportunity for everybody to track what is going into the system and how we report effective utilization. The other component of this risk are the sustainability of the current investment by C19 and RSSH, the lab system that have been upgraded, including the genomic sequencing, optimizing it is very, very important. Oxygen investment, the PSA plant that have been installed, how are we going to maximize them? Then supply chain, warehouses built across the states. Some of the warehouses are still empty in terms of shelf, pallets, and then commodity that will be stored in those warehouses. Surveillance, health sector planning, the same thing. IPC investment has gone there. Then PHC revitalization that is currently ongoing across board. Next step, we've submitted and we are waiting for TROP outcome, just like I said earlier. The next thing is to continue engaging government at all levels so that the operationalization of the C19 and RSSH past investment can be maximized. And then we set aside the resources for insurance as well as maintenance of those assets. Again, we have to also support the National Council on Health decision in 2023, where a budget line was recommended to be dedicated for oxygen management, so that the PSA plant that have been installed, 73 of them have been installed across the 36+1 states. We need to optimize them. Then sustain advocacy efforts on health system sustainability, including domestic resource mobilization. Thank you.
Thank you. Tajuddin, just if federal government is interested in taking something like and eliminating that, does that count as a core finance if assuming government is investing its resources on something that is very prevalent? 20 million Nigerians have hepatitis. To do test and treat, to eliminate that. That's our goal. And we spend domestic resources. Will that count?
It does count, sir,
Okay.
as part of the co-financing.
Thank you.
Thank you, sir.
So I think today is Friday. I'm very keen that we wrap this up quite efficiently. My colleague here is going to move to attend to another meeting. And yeah, so I'll ask three members of the MOC to please offer your comments, and then we'll go to the memos. Dr. Banji.
Thank you very much. Thank you to the ES of the CCM. I think this is a very good presentation. I will first commend the work they've done, particularly with respect to the pharmaceutical grade warehouse across a number of states. Just last week, I know Peter Sands and a couple of people were in Ogun State. I'm not actually sure I saw your picture, CM. I don't know if you were, okay. Okay. But I think for me, it's beyond the infrastructure, right? Or putting the pallets or some of the things there. I think that is one resource that has gone to something I believe will be sustainable because it builds on an existing infrastructure within the system. States that have the Drug Management Agency who are already procuring commodities and so have the resources to maintain that. And I think that's the way we should think about, funding from either the GF or any of the other partners to build on what currently exists. So that takes me to two questions that I have. The first is around the targets that you had mentioned, particularly with respect to HIV. What I wasn't sure was if this is a national target or is a global fund specific targets for the states in which they will operate. I say that because that's very different. If your national target is 100, to get to 95% as an example, I'm not sure that the global fund, using the global fund, or putting that as a global fund target, is something that you need to rethink. I think the second is around also those targets. And I saw on the PM to City one, which caught my eye, you wanted to move from, the goal is to move from, I think, 34% to about 90-something% by 2029. I think it's a bit ambitious. I don't know if I'm wrong. And that's something I maybe we'll just need to take into consideration. It might be useful. I don't know if that has been done, to look at to have a stock take of what we've done in the past and get a sense of why, if at all, we didn't even achieve these targets. Because I can imagine that these were sort of the targets that we had set in the past. My final point then is on the RSSH. So my assumption prior to now was that the RSSH was indeed RSSH, which, to mean that it was system strengthening. But it looks as though this is RSSH specific for the programs. So it's RSSH, but yes, it's only focusing on strengthening malaria system strengthening. RSSH focusing on strengthening HIV system strengthening. So maybe I missed that out, but it will be useful to get a sense of what that is. And on the labs, again, I come back to NCDC and a number of the labs that they have. This might be and should be a useful opportunity to consider how do we coordinate laboratory structures in the states or at a country level vis-a-vis what we have with support from partners or even federal and some of the disease outbreak programs. I think there's an opportunity to explore that collaboration even better using this funding. So again, to the point around what we've seen with the DMA structures and the building of the warehouses, which I believe should and will be sustainable, this may be an opportunity to do that collaboration better. Thank you.
Thank you. So two more. UNFPA, UNICEF, Dr. Berry. But fourth one, the one. So give UNFPA, the UNICEF and FCDO.
Thank you. Thank you very much, Honorable Coordinating Minister. In the interest of time, I will go straight to the point. I was very glad to hear and to see that the verification has been completed for the DLIs that has been unlocked, and especially for the DLI 2.1. I wanted to offer that we will be interested in considering the report that has been used to validate and unlock the DLI, because similar to this DLI 2.1 about the family planning, if you have the UNFPA supply partnership match, that has about $4 million of opportunity that hopefully with this report we can work at unlocking. So I will be very happy to work with the SWAP coordination office to see how we can use this as an opportunity to try to unlock additional resources for the family planning and reduce the funding gap. Also, regarding the presentation by the SWAP office, it's confirmed the gap that we are seeing in HR for health. And in addition to what you already presented, Honorable Minister, about the work that government is doing in absorbing the workforce through the US memo, I wonder if there are some specific recommended actions that we can support the states to implement, so that especially in areas in the southeast and other areas where we are seeing significant gap, we can help to close that. Thank you.
Thank you, Coordinating Minister. I think I'll be short as well. First, there was an ask to the MOC to acknowledge for the release of the verbal and social autopsy study. I think I would support that. The earlier we release it is better. Number two, I'll also be a bit cautious comparing mini DHS with DHS. I think if I understand correctly, the mini DHS is targeted and focusing on areas which are already below targets, reaching very low coverages. But if you're comparing that with DHS aggregates the whole national figures, you may be underestimating the coverage that you're already reaching. So you may actually be reaching more with your interventions. If you compare mini DHS and DHS, just want to flag that to be a bit cautious when you're analyzing that, because both are different parameters. The third point I just wanted to flag, it's suggested in line with your earlier remarks, also to while the BHCPF is a kind of a tokenistic factor to move the systems well, I think as MOC, if everybody finds it appropriate, we also need to be finding ways of measuring that impact and also moving to a more broader sector-wide presentations, if that makes sense. Yeah. Thank you.
Thank you. I think on the mini DHS, if it's a good comment, but we were intentional about it not being a full-scale DHS. We cannot do that every 2 years. But to be very candid, when we did this in 2023, we know 2027 is going to be a major year. We don't know. I don't know yet whether to how far we'll get in, but at least a mini DHS this year will give us a sense whether things are beginning to move in the right direction. So that by 2028, when we have a full-scale DHS, who knows who might be sitting at the MOC and at least we get to know quickly if it's working or if it's not working. And then we have the full DHS that will tell us all the great things that we have done, but not to know, not to miss, if it wasn't working, then we might as well start to correct it rather than to to escalate failure, basically. But it looks like from the data that things are moving in the right direction. So that was the purpose. And it's, of course, not to be compared with the full-scale DHS. Ebere, you have the final word.
Thank you very
And
much.
then I'll
Honourable-
ask CSO, yeah, sorry, Dr. Yes, please.
Yeah, thank you very much, Honourable Minister. My first question is to CCM. In terms of the HIV cascade targets, you mentioned that we are not where we thought we were, particularly on the first target. And I'm just asking, my question is, do we know why? So is it that the data that we had before was wrong, or is it that we have slid back in terms of performance on those targets? So it'd be interesting to understand that. Second, then also to CCM, if you look at the USG MOU, basically what it seems to be implying is a profound shift in the way that we deliver HIV, TB, malaria services over the next 5 years in terms of the way we finance and deliver it. I'm just wondering whether the Global Fund funding request has factored that in, whether you are thinking about making those shifts also in the way that the Global Fund funding structure and delivery structure is also planned and implemented. The other question is to NCDC. I'm sorry, this is from the previous presentation, where you mentioned that your risk assessment is that Nigeria is now at high risk of importation. But I understand that Africa CDC doesn't classify Nigeria at high risk. There are a certain number of countries that they see as high risk. So is there an issue there? Because if you are high risk, that may have certain implications, for countries that are in that.
Dr. Berry, you're bringing us backward.
I know, sir, but I think it's an important point, sir. Thank you.
No, I think we're being very conservative. CDC is very aggressive in trying to protect. So the sense, perception, the risk assessment based on his, but WHO said we are low risk. ACDC says we are low risk. That's what they say. But we know, and our CDC saying we're high risk, so we better go with a high risk and act like that rather than, yeah. But you want to respond? Yeah. We're being a bit more, because WHO sent us a note that says we're low risk. High risk continental, yes, but we are low risk based on the cascade that.
No.
Yes, okay. The CDC, please go ahead.
They gave us high risk, but the other factors we considered was movement of people from that area down here. That's one. Our local population here, the huge population we have, the migration issue, because we tracked some migration data from that side up to the northern part of the country. We're high risk. And again, we looked at the airline movement. There are 4 major airlines: Ethiopian Airlines, Kenyan, Uganda, and this that come here. 2 airlines are Sky and Airpeace. They go to other regions, other Western regions here. If you combine all this again, it makes sense again using the data we use we are high risk.
No, I think what you're saying, we should take it low risk. But if we have one case, all the world will get on top of us. So as far as we're concerned, we're not taking any chances. We better agree and act and behave like we're high risk, regardless of what anybody else says. I think that's our position. So the SCDCs, if we say low risk, what do we gain by it? We just go to sleep. Everybody goes to sleep. But if you say high risk, everybody is sort of on top of it. Now, WHO, give us a final word.
Just very quickly to say that WHO has done 2 risk assessments, and both 2 risk assessments are saying that the entire continent is high risk, but because of the proximity of DRC and Uganda, 11 countries are high priority within that high risk. So it's not, we are not saying that is low risk, Nigeria is low risk.
So that's very consistent with our position. For us, we don't care what WHO ACD say. We're high risk till this is over, so that we act accordingly. Because the day one case comes to Nigeria, all eyes will be on us, and we move from very low risk to the problem, and we don't want that to happen. Dr. Lekki, CSO, just to have your voice, but be brief, please. Then CCM, you'll respond. Yeah.
Thank you, Honourable Minister. Couple of things really, and I'll make it very quick. One is that I think these presentations and in fact this meeting is a commendable thing. And when you look at it historically, we're actually moving in the right direction and expanding the voice around the table. And it's important that as we have representatives from the subnational level, I saw Dr. Banji here, this should be translated to that level too. That is the way we can make the required progress as the NHSRII intend us to do. I want to commend also this very innovative, mini DHIS. I hope that I heard the minister say something. I hope doesn't mean that it's going to be implemented within the NHSRII alone. It becomes something that we do periodically. Because for a data staff country, we know there are issues with the data if we interrogate them more, but I think it's a step in the right direction. We're beginning to see data on outcomes and processes. So it's a very good thing that we need to sustain. Just a quick thing about the presentation. Presentation by the NHIS and the Primary Care Agency, particularly on the issue of eligibility of enrollment. I think we need to look beyond the NIN because the regulation says that we should use both the NIN as well as the social register that is acceptable. And there is social register from NASCO, and we at the Health Sector Reform and Algon, we are working with NASCO to disaggregate that data to the local government level. So that should be used as a benchmark in authenticating registration for enrollment. And also, we're also working, I think the issue of the saliency of World Development Committee has not really come out in most of our discussion. That is the fourth governance for primary health care in Nigeria, even beyond primary health care. And I think we need to factor that in looking at how the functionality of the PSI is still being used at the health facility level. We said about 42% can confirm or have been confirmed as having receiving the basic. Why 42%? The money is going regularly as disbursed, so we need to move it beyond 42%. We also need to authenticate that that's true. The work we are doing in WDC, well, we'll be working with the Secretary of MOC for the next meeting to present some of the work that we are doing jointly with Algon. Just final note, Algon and Health Sector Reform Coalition and the CSO, we have a platform in which we review the program for this, for every meeting of MOC, so that whatever I'm saying here is a joint position of both Algon and the CSO. Thank you, Minister.
Thank you. So, swap office, there was a question for you, and CCM. Who will go first?
Thank you, Honourable Minister. I'll go first. I think I had 2 questions, and I think both of those suggestions are welcome, but I wanted to give some context. On the first question related to the FP procurement, I think we're seeing a reorientation now towards a government-led approach. I think one slide that was shared showed how the harmonization between NPHCDA and the ministry is leading the quantification, forecasting, and integration of distribution plans. So a government-led effort, and I'm quite pleased too that that harmonization included not just the ministry and all the relevant departments, but also UNFPA and some of your colleagues, as you're aware. And I think now that the FP expenditure has been validated by the IVA, and in fact, more recently, we received notification from the bank to approve the disbursement, I think we'll absolutely be in a position to share so that we can leverage any additional financing. And I know the team has been meeting with you in that regard. So I think that's something we're pleased about. So that's first. The second question was around human resource. Honorable Minister, colleagues, you will recall that one of the DLIs on the HopeGov is related to human resource. So in fact, 30 states have, as you heard earlier, as part of the work of the HRH, have submitted their human resource baseline norms and targets. And so we have those HRH plans for 30 out of all of the states. And in fact, the independent verification report from HopeGov is out, and a number of states in year zero will be benefiting from incentives on human resource. And this will be an important part of helping to bridge the gap as we implement the USG MOU intervention. So I think that too will be shared, and I think we'll be having further engagements related to that. But just to add, over.
Thank you. So you'll get the report. UNFPA, sorry, you verify. CCM.
Thank you very much, sir. Just to respond to Dr. Ebere first, when it comes to the issue around implementation arrangements, considering the current shift at the country level, that's why in my presentation I did mention that we've reduced the number of principal recipients to 5, and 4 out of 5 principal recipients are government entity. So receiving the money directly from Global Fund, and then it will be, so we use government system to deploy, and then states will play significant roles. And in my presentation, I also mentioned the fact that we now engage more with sub-national level, the states through commissioners forum, the director of public health, and then the ALGON. They will have critical roles to play in time of implementation this time around. Then when it comes to the issue around the data for lack of reports that is available, but for the purpose of the conversation, the main issue is around data system. So we've been reporting over the years, and then there has been several activities in time of search, which talks about hand-to-hand activation of facility sites. Unfortunately, when the state health impact indicator survey was conducted, the results did not match what we've been getting in time of report. So which shows that because we don't have credible system when it comes to validating the data we've been carrying over the years, so we cannot continue with that number. That UNH rejected the number, and that they are not, because UNH did not report Nigerians' data last year, and they said the only condition for Nigeria data to be reported this year is for them to use the AIS from Akwa Ibom as a baseline to decommit the number of people we currently have on treatment, and then that also affected the first 95, which is the PLHIV that knows their status. Then to move to Dr. Banji's comments around the targets, the answer is yes. The target is for Global Fund supported states. The hand-to-hand states, we have 8 hand-to-hand states for HIV/AIDS. Then for 14 states where Global Fund resources will be for malaria, HIV, and TB. Not fully malaria in the 14 states, but malaria in 13 states, full HIV in 8 states, then TB, HIV in 5 states. So put this together, Global Fund targets to achieve from 34 currently to 90% for PMTCT, because we are trying as much as possible to reduce our transmission rate to minimum of 5%. Before the decommissioning of the number, we are currently at 68%. The first time Nigeria tested over 8 million pregnant women was in 2025, because we've already activated both confectional and non-confectional facility across the 36+1 states. We are currently providing PMTCT services in over 35,000 facilities in Nigeria. So that is the reason why we want to move to 90%. Then for RSSH, the slides, maybe by the time we share the presentation, there is one slide that talks about RSSH within HIV-TB. That is cross-cutting. Then the 42.8 million is RSSH that will strengthen the system. So it's in two streams. So one is 42.8 million that will strengthen the system. Then the one that is embedded within HIV-TB, it's for us to also use it as a fulcrum to also benefit and strengthen the system further, considering the reduction in our envelope this time around and then the available resources for health system strengthening. Thank you.
Thank you very much. I think a lot has been discussed in this meeting. I would like us to close this segment and move on to consider the memo so that we can get out on time. So, Secretary MOC, take us through the memo.
Thank you, Honorable Coordinating Minister. We have just one memo for this MOC meeting, and it's essentially a memo of the MOC for disbursement of the Basic Health Provision Fund second quarter 2026 Implementation Fund. We'll be using statutory allocations of January, February, March, and a portion of April 2026. So the memo seeks a total disbursement of 32,880,443,906 naira 25 kobo only. Just a bit of a background is that over the course of the first quarter, January to April, BACPF has received an average about 8.9 billion January, February, March, and April. In May, we received 13 billion, an increase, and that's a total now of 48.9 billion. If you aggregate all of the releases January to March, it comes to 26.8 billion. Our ask of the MOC is to take all of that and a portion of April, about 6 billion, to make up to 32.8 billion, to be consistent with the previous releases. The previous disbursements have happened. We think and we see an increasing trend in releases coming from the Consolidated Revenue Fund, but we want to see the pattern over the next coming months. So, Honorable Coordinating Minister and MOC members, there are two prayers here to approve the disbursement of a total sum of 32,880,443,906 and 25 kobo as second quarter 2026 BECPF implementation allocation to all of the gateways, states, local government areas, being released sums from January to March and a portion of April 2026 statutory allocations, and that this disbursement should happen in August, in another 2 months. Thank you, sir.
Thank you very much. I think I'll open it up to members of the MOC for comments or endorsements. It's very straightforward.
Thank you very much. Yes, CM and members, I think this is pretty straightforward. I just have a question. Why August? Just one question, just to be sure. I'm not sure why we have to wait for August for the disbursement.
Okay.
We have just disbursed for Q1. We think that it will take time for states, for gateways to also disburse, and then for it to be utilized, and then retirements to come back before another disbursement happens. So we're just giving a 2-month window, 8 weeks. That's why we propose. But of course, if retirements come back sooner, quicker, we're happy to proceed.
Dr. Berry.
Thanks. Just one question. Why is the releases why are they 50%? Any particular reason why only 50% of the funds are being released?
In advance of approval of the budget, what would happen is that the Accountant General's office preemptively will release 50% of what is anticipated, pending when the budget becomes active. So that there is no lacuna in the system. So we get 50%. We're now seeing, as I reported, that in the last release we received increased from the previously 8.9 billion to about 13. We're waiting to see further collections to understand what that figure is.
Thank you. I think we have to acknowledge, I mean, something that is not very, more than 325 billion has been disbursed through the PHCPF in the last 12 years. But 240 billion were only in the last 3 years. That says a lot. For 10 years, that's 100 billion. In 3 years, almost 240 billion has been disbursed to states. It also brings to question the co-financing of the states and local governments. If the 40% co-financing has been obligated by the states, that would have meant in the last 3 years alone, we would have had almost 400 billion in direct facility financing. Federal government has been standing its grounds. And now we're getting to the point where we would be asking states to lean in. So the federal government, I think, and the Accountant General have been trying very hard to pull this PHC system forward in this sector-wide program. And we have results to show for it. So the plumbing is there. Now is to double down and actually get the subnational resources also to match that. Yes, a comment, and I will ask that we please vote on this, and then we. Are you from France?
Thank you, Coordinating Minister, sir, and the MOC Secretary. Mine is just a suggestion. Going forward for memos like this, it would be nice if the MOC Secretariat can present it in form of a matrix with disaggregated payment, identifying by gateway, states and local government each that is getting. In that way, members will be able to see, will have a snapshot and have a view of what every state and local government is getting, as well as the gateways. And that may also reduce errors in the events that there are, and for corrections before approval and payment.
Thank you. And that should be by the MOC Secretariat, give that breakdown, and consistent with the red letter that we had issued, so that folks can be able to track. We have CSOs here, we have the media, that it is visible. There are no lost in translations. So that is something that the MOC Secretariat will do. Now, let me just open it. Any objection to proceeding with this approval? CCSO saying no objection. Any objection? Who moves the motion to approve? CSO move the motion. Any seconder? Seconded by WHO. So thank you. I think this has been decided. Thank you. AOB. So let me just bring on AOB, which is the 5th high-level global ministerial meeting on microbial resistance that was scheduled to be end of June. As you all know, I believe, but I use this opportunity to re-emphasize that given the public health happening in the continent, the recency, the high risk, we had taken a decision in consultation with the global actors to move it to December 6 to 8, 2025. That decision was taken in also consultation with the Troika, the Kingdom of Saudi Arabia, the Sultanate of Oman, who have preceded Nigeria in the presidency, and also with the joint quadripartite secretariat and the quadripartite organizations, the WHO, UNEP, United Nations Environmental Program, FAO, Food Agriculture Organization and the World Organization on Animal Health. It was put together by the One Health Ministers, Minister of Livestock and Development here, the Minister of Agriculture, Minister of Environment, and ourselves and the Ministry of Health, and the Global Leaders Group on Antimicrobial Resistance and the multi-stakeholder platform, which we have discussed with them yesterday again. And there is support overall, and we now have a roadmap for December 6 to 8 to host the 5th Global High-Level Ministerial Program on Antimicrobial Resistance. I'm saying this because the Commissioners of Health, the primary healthcare agencies should be aware, and you should be part of that, because it is a national effort, not just a federal government event. Even it's a global event. I want to put that as an AOB to this group. Any other business to bring up? No, it's Friday and we're 2 minutes before our intended closing time. Next steps.
Thank you, Honorable Coordinating Minister. At the end of today's proceedings, we've highlighted a few items. Under the guidance of Honorable Coordinating and MOC members, a decision has been taken to have private sector representation in future MOC meetings on an annual rotatory basis, and that was going to be convened. We're going to convene a conversation with the private sector actors to determine and decide how they want to be able to make that work. There were a lot of conversations around gaps, and the Honorable Coordinating Minister had again invited development partners to work with government entities to continue to address those gaps, recognizing that not all health-related activities are being discussed in the room. In terms of the presentation from the NCDC and the state of preparedness of the country, a small team has been put together consisting of the NCDC, DPH, DHS, WHO, Africa CDC, and the MOC Secretariat to within 6 weeks report back to the both ministers in terms of status of the molecular diagnostic labs and isolation centers and for decision making, while the substantive reports would be presented to the MOC at its next meeting. There's also the directive to bring forward for Honorable Minister's signature to write to 36 states and the FCT who have consistently received allocations from the BHCPF to articulate what expected 25% counterpart funding is for their contribution to the fund. And we've presented the memo for Q2 disbursement, and I think I don't know if the MOC had approved. Okay.
Yes. I think thank you, sir. The number 3, the responsible persons. Please, you can project it again. The DPRS. I remember when he was saying it. He said the DPRS should be part of it. I respond number 3. So
add the DHPRS as part of the okay.
There was also a directive from the coordinating minister to write a draft letter to send to the governors to ensure empanelment of the remaining 2 states.
Yes.
And then, sir, we also agreed that subsequent disbursements, there is need to have a matrix with the disaggregated data. Okay, thank you.
Yes, put it in the action steps finally, and also you'll publish it so that people can be able to track per state. But that's something that you will do. So I think the next steps have been presented. Closing remarks. Yes, WHO. Yes. Yes.
Thank you very much. He said gaps identified today. Call on development partners in the MOC to see how this can be addressed. It's a little vague, so we need to probably have MOC help us identify some of those key gaps that we can look at. Thank you.
Okay. So how those identified gaps by the Secretariat can be addressed. Yeah, so that it's a joint, it also is a joint responsibility. That's why we're all in it together. So I want to thank each and every member of this expanded MOC for very constructive comments, interrogating the data, your feedback, your suggestions, the candor with which you brought yourself to the table. So on behalf of myself, my colleague, the Minister of State, the Permanent Secretary, and the Ministry of Health, I would like to thank you all for this very successful MOC. And I would ask one of us to move for the adjournment of the, yes, Dr. Banji.
I, Oyebanji Filani, hereby move the motion for the adjournment of this meeting.
Thank you. Thank you, Dr. Banji. Any seconder? Director of Hospital Services, second. So meeting adjourned till when, and I think I've asked the MOC to have fixed dates so that we know ahead of time and we put them in our calendar. We've so far been consistent, but we need to know ahead so that we have it on our calendar, and you'll communicate that to us so that we all calendarize it, I think. So thank you very much. I think the item 16 says media engagement and press briefing. So the members of the media, I would ask that all these members of the expanded MOC are subjects for your interrogation. I would just make some preliminary remarks, escape, and then leave the heads of agencies, directors, and our partners to answer whatever difficult questions that you have. I think as chair, can you come here, Secretary, so that you can guide me. So, all right, very good. So let me just, okay, no problem, thank you. Yes. Thank you. Yes. Oh my goodness. You see, this is all in the interest of transparency, so that Nigerians are also aware of what we are doing. So bear with us, and I hope each and every one of you will be willing to answer questions that may come up. So today, please, can we have one room, please, as we speak to Nigerians? Today, the Honorable Minister of State for Health and myself chaired the 15th Ministerial Oversight Committee on Basic Healthcare Provision Fund, on the Health Sector Renewal Investment Initiative, and other key national health programs. This is a quarterly meeting which reviewed progress, looked at challenges, and made decisions on where we go next. The expanded ministerial committee comprises federal government agencies, the Ministry of Health, the state commissioners of health, state primary healthcare agencies, state health insurance authorities, our key development partners, civil society, and other relevant ministries. What we discussed was the progress that is being made in implementing the Nigeria Health Sector Renewal Investment Initiative, which was flagged by Mr. President, President Bola Ahmed Tinubu in December 2023, which has garnered steam, and we're beginning to see a lot of progress. That progress is thanks to resources that were the anchor resources of the Basic Healthcare Provision Fund. In the last 12 years of the Basic Healthcare Provision Fund, 339 billion were disbursed to states, out of which 235 billion were disbursed only in the last 3 years of President Bola Ahmed Tinubu's administration. This shows the intensification of the effort to expand primary healthcare under this administration. And with those resources, primary healthcare centers, more than 8,000 of them, all over the 36 states and the Federal Capital Territory of Nigeria, have been receiving resources on a quarterly basis for primary healthcare through the primary healthcare agencies, for health insurance through the Vulnerable Groups Fund of the Health Insurance Authority and the state health insurance authorities, through NCDCs for outbreak control, and also for the emergency medical services. With those resources, we have seen continued progress in terms of utilization of healthcare services, expansion of emergency medical treatment. 35 states already have their own structures, while 2 states, Benue and Imo, do not have their own set structures but are reliant on federal institutions in their states. Through that program, more than 130,000 personnel have been attended to using the emergency medical services provided by the Basic Healthcare Provision Fund. The NCDC has been using its gateway to provide support to states in outbreak control, trying to assess, detect, enhance surveillance, and help states to be ready to respond for cholera, Lassa fever, and other diseases like cerebrospinal meningitis, and even now with the Ebola virus disease that is in the Africa region, even though it is not in Nigeria. As you may have heard, a few days ago, the Ministry of Health used resources from BHCPF to approve the disbursement to all the 36 states to enhance their preparedness against Ebola. This is complementary to the great stride, the great decision of Mr. President to set up a presidential task force that is multi-sectoral so that Nigeria enhances its own preparedness. The Primary Healthcare Agency reported, confirmed the more than 3,000 primary healthcare facilities that have been revitalized to level 2, and almost 1,000 that are in various stages, as well as assessment of the facilities that will be expanded from the more than 8,000 to 17,600 that will be receiving the higher level of disbursements from the direct facility financing, with the provision that there will be equity adjustment so that this primary healthcare centers that have the population with burden of disease will have that factored in the resources so that it's not shared just equally. We also receive report that the resources from the federal government, 40% of them are being used for drugs and commodities. And importantly, some states are complementing the federal government efforts in financing the primary healthcare system. We call on all state governments to co-fund the Basic Healthcare Provision Fund. The 25% from each state and 15% from local governments will extend the basic healthcare provision by an additional 40% on top of what the federal government is providing. So far, that has not been very clear. So the MOC decided that we will plead with state governments and local governments to deliberately co-fund this federal government effort that is coming from the CRF of the federal government. On outcomes, we've seen increases in skilled birth attendance. We've seen increases in utilization. We also reviewed the preliminary results of the mini DHS in 2026. So 2 years after the NHSRI, we're beginning to see data that shows progress in the key outcomes at the population level, whether it's on antenatal care, skilled birth attendance, contraceptive prevalence, immunization, child health, HIV. We're seeing an upward trend. Now, this is mini DHS. It's not the population survey that will be done in 2028. But the purpose was to see if we are making this progress, then we shall double down. And we are glad, in fact, to see that there is progress. Health insurance has expanded. More than 6 million people have been added to health insurance rolls in the last 3 years. When this administration came, we had 16 million. Now we have 22 million. That is over several decades, and now we have added 6 million. That means we are making really good progress. More than 40,000 women, more than 48,000 actually, women have been served with comprehensive emergency obstetric services free, reviewed and paid These are lives, these are women who would have had challenges of things like cesarean section that the federal government resources has resulted them and their families saving those funds and saving their lives. And 237 facilities were the vehicle. Free fistula program of more than 4,771 women who had had their vaginal fistula repaired, and they are being integrated in society. And through the neonatal program, more than 2,900 newborns had been served. All in all, we are also seeing expansion of insurance using the Global Fund resources of more than 40,000 enrollees through the NHI, which is a pilot program that we're doing in collaboration with the Global Fund. All in all, we have seen tremendous progress, but the progress is fragile. It depends on our continued commitment. The federal government's leadership, the states and their agencies, and our development partners. There are still challenges in terms of the availability of these resources in the front end. Challenges of utilizing those resources in the front end well. But we are committed to continue building on this effort so that Nigeria's health outcomes improves. And as we have seen on the continent of Africa, a recent report showed that Nigeria's health system is fourth in the continent after South Africa, Tunisia, Kenya, and then Nigeria, even ahead of a country like Egypt, which is sometimes where Nigerians go for care. So we are seeing true progress with data to back it. And the 32.8 billion naira that was approved for disbursement will follow, will be channeled to the states, will support health insurance, will continue this good work alongside other interventions through the sector-wide approach. On human resources, we also discuss the challenges, particularly in some regions, particularly the Southeast and South and Southwest, where we're seeing movement of staff from primary healthcare centers to higher level facilities. Primary healthcare is the foundation of Nigerian health system. It is the responsibility of states and local governments. So we call on state governments to ensure there's adequate staffing for primary healthcare at the state level, while we're expanding the training capabilities in collaboration with Ministry of Education to ensure that our health system continues to move forward. So I will stop here. I thank all members of the MOC, and for members of the media, you are free to ask them all the difficult questions. Thank you very much.
Attention, please. There will be a lunch in the main hall, please. Please. Please, let's meet at the... Please, let's meet at the main building. There will be a lunch there.
Ladies and gentlemen, please can we go outside for